Assalamualaikum warahmatullahi wabarakatuh. Very good morning, ladies and gentlemen. Welcome to the webinar on occupational cancer in Malaysia. This webinar is organized by University of Malaya, National Institute of Occupational Safety and Health, and the Academy of Occupational and Environmental Medicine in Malaysia. I would like to thank everyone who joined us today in this webinar. We have up to 200 participants actually registered with us from Malaysia, from Brunei, and also from Indonesia. We'd like to welcome everyone in this webinar today. Our main objective today are to increase the awareness among our medical practitioners, especially in Malaysia, regarding occupational cancer and its notification. And then we also want to discuss the issues faced by our medical practitioner in identifying occupational cancer cases in their clinic. At the moment, if we can see in Malaysia, there's a limited reported cases on cancer. The last report was in National Cancer Registry report, whereby the Malaysia Cancer Register, bronchus, lung that were listed as third most common cancer overall, which account up to 10.2% of all cancers. And the most common one was breast cancer, followed by colorectal cancer. However, in male, cancer of the trachea, bronchus, and lung was among the most common, accounting up to 16.3% of all cancer among male. So it's kind of difficult for us to estimate the real magnitude of workplace exposure of hazard that leads to this cancer, as it is difficult in proving the causation. And further, there's a long lag time between the exposure and the development of the cancer itself, which may take up to 30 years. And occupationally related bronchial carcinoma there's no difference between the pathological of bronchial carcinoma and also that primarily caused by tobacco smoking. That's among the challenges that faced by our occupational health doctor or our medical practitioner to diagnose occupational lung cancer. So we want to hear more on these issues and what are the challenges in diagnosing occupational cancer in Malaysia. With us today, we have three distinguished speakers that will enlighten us more on these issues. So we have lined up the program. We'll start with Prof. Victor Ho. He will discuss on the occupational cancers, on the cancer, prevalence of cancer in Malaysia. What are the current perspective of cancer in Malaysia? Followed by Dr. Jasima. She will be discussing on occupational carcinogen exposure, and then with us also we have Dr. Wong Chi Kwan on the lung cancer screening program and also lung cancer incidents in Malaysia. So without further ado, I'd like to invite Prof. Victor Ho. All right, Prof. Victor Ho is a professor of public and occupational health in University of Malaya, Faculty of Medicine, University of Malaya. He is currently heading the Occupational Safety, Health and Environmental Unit in University of Malaya Medical.
Thank you, Prof. Mazuki, for the kind introduction, and welcome everyone to this webinar, Occupational Cancer in Malaysia. Today we are going to discuss about occupational cancer and current issues and development. I am Professor Victor Ho from the Center for Occupational and Environmental Health, University of Malaya. So before we start looking at occupational cancer, we'll need to look at occupation-related injury and diseases. So in 2017, the International Organization International Labour Organization has published a report that says that the resulting health problem from economic losses affect first and foremost countries with less developed prevention culture. So the number of occupational related people dying for diseases is almost the same. It's around 2.78 million. It have not changed in the last report, and basically it's through work-related accidents and diseases. And occupational injury actually kills 380,000 people, but there's more people dying from work-related diseases than occupational diseases. So it's important to know that if you are in the safety and health perspective, you will know that most of the time you look at occupational accident and you think that that's the main thing you see, but when you focus more deeply, you know that the data would say that there are more cases of occupational death due to work-related diseases compared to occupational accident. And we know that 160 million new cases of occupational illness are diagnosed yearly. Of course, this has something impact on the financial burden, and basically when we're talking about occupational disease, also we need to focus on not just the number of diseases that's happening, but also the financial burden towards the individual and also the country. So financial burden of compensation, healthcare and rehabilitation is huge, and it's around 4% of the world's GDP. So these numbers also have not changed over the last period. So the 4% is still there, but it's in developing countries it's worse. It's up to 10% of the GDP. While injuries number have gone down in developed country, it continue to increase in the developing country. So the thing is, we are basically in a developing country. We need to focus on that, need to identify the burden of occupational diseases, which we would present later, that is lacking, especially in Malaysia. So among the 2.4 million cases of the 666,000 are due to occupational cancer, and occupational exposure caused 5.3 to 8.4% of all cancer among men, and almost 30% of all lung cancer. So when you look at these figures, you would basically wonder why the number of occupational related cancer incidents or compensation and also notification in Malaysia is basically low. I will present this later to discuss on the issue. So the thing is, why is it still low? Lung cancer actually, out of the occupational cancer, lung cancer actually contribute the most. Between 54 and 75% of occupational cancer are due to lung cancer. So we hope that Dr. Wong Chi Kwan can basically discuss and identify, share with us the current issue of lung cancer in Malaysia, and how can we, as a physician and occupational health doctor, help to basically identify occupational lung cancer. These are the numbers of compensated occupational cancer as reported by SOCSO. So all these numbers basically comes from their annual report, and they used to report the different category of cancer that they get, but because of the data which is not really accurate, so they have basically stopped reporting those numbers since 2017 and since 2017. So we only have the total number of cases. All right. So the total number of cases is basically very low, between 19 and 6 per year, and it is basically contributing to less than between 3.35 and 0.12, less than 0.1 per 100,000 cancer per 100,000 active contributors. So the number of cancer cases per contributors and the total number of cancer cases that has been compensated in Malaysia is very, very low. Although if you look at it, the people who actually insured by SOCSO before 2016 are from the higher risk category. Basically, they are all blue collar worker instead of white collar worker. So the number of cancer cases should be higher. The question is, why is the compensated number of cancer cases is very low among our SOCSO contributors? Those issues we need to discuss later in the forum, but currently we're just presenting the numbers and then discussing what may be the issue of the low numbers. So the number of cases basically varies between 19 and 5 and 19 over yearly, and compared to the number of occupational diseases, which is on the rise from 900 to 4,000, and the percentage is actually of cases of cancer among occupational diseases is only 0.17%. So it's less than 1% of the total number of reported occupational diseases that we see are due to cancer. So we need to focus on what is the issue with that, and how can we improve on that. That's why we are having this discussion today, and also the research itself is basically on identifying problems that is faced by the practitioner on identifying or on recognizing what is occupational cancer and how do we report occupational cancer. So since the data in Malaysia is very there's not much data on occupational cancer in Malaysia. Also, there's not much research on occupational cancer in Malaysia, especially on the prevalence of cancer or different type of cancer. So we would basically discuss on cancer that's happening elsewhere in other countries. So the first discussion we're going to focus on is the occupational cancer in UK. All right. So the UK occupational cancer compensated in UK. This is basically the same as what is done for SOCSO in Malaysia. So yearly they have around 2,374 new occupational cancer cases per year, and for us it's only 19 cases. And the population of UK and the population of Malaysia is almost the same, and of course now Malaysia have more higher population compared to the UK. So it's equal to amount for 1/4 of the total compensated cases. So you look at the data in Malaysia, our percentage of compensated cases of occupational injuries is only occupational diseases is only 0.17%. So it's very small compared to the numbers that is basically reported in the UK by the Health and Safety Executive. So majority of the cancer is basically related to asbestos, and of course there's mesothelioma, which is 2,995 cases, asbestos-related cancer, and non-asbestos related cancer only 18 per year. So if you look at this figure, you ask a question whether it's because of the asbestos use. So the occupational cancer compensated is basically look at it that maybe most probably because our use of asbestos is low, or is it our reporting of asbestos-related diseases is low. So with this one, we need to discuss. So later, when Dr. Wong present the cancer in Malaysia, we will be able to discuss in our forum whether this is the way and how can we improve on reporting of asbestos-related diseases in Malaysia. So if you look at non-asbestos-related diseases, the number is actually 18 per year. It's almost similar to what Malaysia have of cancer in Malaysia. Compensation of cancer in Malaysia is around 19 to 8. So the number almost is the same, similar to UK if we remove asbestos. So the issue now is it current the true figure, or is it different from what we are looking at now? Of course, the total cost of cancer to the society, this occupational cancer, is also very high. So lung cancer estimated to cost 6.8 billion, mesothelioma 3 billion. And breast cancer 1.1 billion. So lung cancer and mesothelioma are basically related to asbestos, and breast cancer is related to second-hand smoke. So basically they consider second-hand smoke in the workplace as a cause of occupational cancer. So are we considering that or not? And how, if we are considering that, can we consider that as occupational cancer? So the other discussion is on UK total annual cost of society, new cases of work-related cancer. This is basically look at the cost. This is to break down the cost. What is the most important cost? It's not just health and rehabilitation related cost, but the cost is calculated based on the human cost. It means to the year of life loss, and also to the productivity cost because of the person not being able to work. So the cost is in millions, so it's basically around 11 billion of human cost and 500 million of productivity loss cost. So the thing is not just giving treatment, it's not just the management of the case, but it's a loss to society because of the year life loss due to the disability caused by cancer, both for fatal and non-fatal cancer cases. So the total cost is around 12 billion per year for the total cost of cancer, work-related cancer. So that is quite a high number. That's why the number comes up to around 4% of the GDP, gross domestic product. I think everyone would know this classification. So basically, the International Agency for Research on Cancer every year would have some meetings to discuss on how to group the cancer into 4 groups basically. But in 2000 they have not reported the group 4, which is non-cancerous, and usually the group 4 non-cancerous has only 1 agent. So if you look at yearly changes, the number of agents classified into group 1 will increase over the years, and currently there's 121 known carcinogen, and 2A is probable carcinogen to human. There's 2,088, and possible carcinogen is 303. Why are we discussing this here today is just because the next slide we will talk about a study that's being done to estimate the cause and also the number of prevalence of global cases of occupational cancer based on the 18 hazard that is classified under group 1 from the IARC. So in the following few slides, I will discuss on the global and regional burdens of cancer in 2016, arising from occupational exposure selected carcinogen. This is basically a systematic review of the global burden of disease study 2016. So this is the latest study on global burden of disease. So this will give us an idea of what are the burden of diseases that is happening, and what's the cancer cause of the burden of diseases, especially focusing on occupational cancer. So method, basically what happened is that they take 1.14 IRC group 1 occupational carcinogen, and estimation was done using population attributable fraction, which is basically to look at how much of the diseases is caused by cancer, and based on past population exposure, prevalence, relative risk from literature, and also exposure information is basically primary from the CAREX or Carcinogen Exposure Database. So about exposure information, Dr. Jasima will basically be able to discuss with you about how to look at carcinogen exposure databases, which she is trying to develop one for Malaysia, so that we can understand what are the risks, what are the carcinogen available in Malaysia, and how much of it is it, and what are the estimate that we can get from number of cancer cases, although we don't have number of cancer cases compensated or notified. So the research actually looked at 8 primary cancer sites, which is breast cancer, and breast cancer is basically caused by secondhand smoke. Kidney cancer, trichloroethylene, trachea, bronchus, and lung is grouped as lung cancer. So the agent is arsenic, asbestos, beryllium, cadmium, chromium for visa engine, and so secondhand smoke. Nickel, PAH, polyaromatic hydrocarbon, and silica. Larynx is asbestos and strong inorganic acid mist. Leukemia is benzene and formaldehyde. Mesothelioma, asbestos. Nasopharynx is formaldehyde, and ovary is also asbestos. So these are the 8 cancer sites that's considered in this study, and from the 18 IRC1 carcinogens. So from the estimate, basically they estimated that around 349 million cancer cases death occur, and out of those 79% are male, and lung cancer is the highest, of which the highest percentage, and followed by mesothelioma and larynx. This is important for us to know, that because it's lung cancer, and of course if you look at lung cancer, it can cause not just from asbestos, but also from arsenic, beryllium, cadmium, chromium, visa engine exhaust, secondhand smoke, nickel, polyaromatic hydrocarbon, and silica. Of course, most of the lung cancer that was compensated in the UK is by asbestos, but other chemical also can cause lung cancer. So the question is, are we able to? Why are we missing these cancer or lung cancer cases? lung cancer as an occupational cancer, although we do use these chemicals in Malaysia. And also we do have exposure by our workers to diesel engine exhaust smoke. So risk factor responsible for the cancer, as I mentioned earlier, most of it is basically due to asbestos, and asbestos basically causes the largest amount of occupational related death due to cancer, followed by secondhand smoke and silica and diesel engine exhaust. And of course, we know that Malaysia also we have silica, but the number of cases of silicosis that we've seen yearly is very, very small. And how can we not just the pneumoconiosis that we see that is considered to be silicosis is very small, and the diagnosed by our respiratory physician also is very, very low. The other major agent is basically your diesel exhaust, diesel engine exhaust, which we did not consider, and we did not look at it and in a more holistic manner. Common cancer site, as we know, is basically lung, followed by and then larynx. So lung and larynx is the two most common cancer sites when it's related to occupational cancer, and most of it, as I mentioned, is due to the asbestos, followed by silica, secondhand smoke, and diesel exhaust. And larynx cancer is due to asbestos and also strong inorganic acidness. So how much of those years, basically when we talk about cost, we look at the human cost, correct? So the human cost is calculated by using the disability adjusted life years. That means years life lost due to disability, either due to premature death or due to because of not able to function fully. So this is called so-called disability. So 7.2 million DALI is lost due to cancer, and 3.4%, and it basically represents 3.4% of all DALI lost amount of the population. So as the same actually, because of lung cancer, it's the highest prevalence in among occupational cancer. So it basically contributes to the highest DALI from that perspective. So lung cancer is 8.4%, mesothelioma and larynx cancer is 2.3%. So this is the example of how people calculate disability adjusted life years or life years lost due to cancer. The information below is basically taken using female breast cancer as an example. So if there is, the first one is incidence. On the top is basically looking at focus on non-fatal carcinoma, and on the bottom one is to focus on fatal carcinoma. So we look at non-fatal carcinoma. When you diagnose a case, basically diagnosis and treatment will take 2 months. State of after curative primary treatment, the remaining 5 years is basically around 4.8 years, and survival with long-term sequelae is 22 years. So these are the years life loss basically subtracted from the disability adjusted life years. But of course, we know that if you die from cancer, the years life loss is basically less because of you die earlier, but the year life loss is basically still high. So diagnosis of primary treatment in 3 months, in remission in 3 months, determine pre-cancer 1.5 years, and terminal stage 1 month. So it got there. So this is how the DALI is calculated. This is just to give you an idea of when we talk about DALI and years life loss, what we put in. Basically, we put in the diagnostic and therapy time, we put in the curative or remission time, and then we look at the long-term sequelae of the cause of the years life loss. The other way of looking at cancer, occupational cancer, is what we call population attributed fraction. So population attributed fraction is basically how much of the attributed risk or attributed total death is due to cancer. So earlier we have presented that 3.9% of death are due to occupational cancer. That means out of the total number of deaths of occupational disease, 3.9% are due to occupational cancer. And of course, because of the higher exposure among male, it is higher in male as compared to females. So what is the change in global attributed death due to carcinogen from 1990 to 2016? So this basically presents a death per 100,000 population. So we see that there is actually a trend of decreasing trend of asbestos because of the decreasing asbestos use, because of the banning of asbestos in many countries, in around 55 countries. And of course, Malaysia have not banned asbestos yet. I think Indonesia and Brunei may be on a better path than Malaysia. And secondhand smoke also that's decreasing because there's a banning of smoking in the workplace. Silica is also decreasing because of the understanding of the exposure to silica. But of course, we understand that there are new ways of being exposed to silica, and that becomes a problem in many countries. Some of it in Australia and also in Italy, when they basically found that silicosis was associated with installation of a kitchen hardtop, where the hardtop actually contains a lot of silica in their as one of their component or quartz. And the other thing that's on the rise is basically diesel exhaust smoke, which is basically 29%. Of course, this will come down in the future years because of the migration from diesel engine to electric engine, especially in many countries that they're using electric buses instead of diesel buses. You can see it in China, where there's a large amount of buses are basically not diesel anymore, so the numbers will come down. So to look at this, we look at that this is traditional hazard that are here: asbestos, secondhand smoke, silica, and diesel exhaust smoke. So most of it is coming down. So this is a good indication that the cancer in the future would come down, especially occupational cancer. The other way of looking at it also is that because of the decrease in number is because of us moving from blue collar to white collar, from us basically focusing more on office work rather than on minings and on other kind of work. So Malaysia is quite lucky in the sense that our mining operation in Malaysia is quite small compared to countries like in Australia or in Europe. That's why the asbestos crisis is basically higher in those countries. The other issue also about asbestos that we need to consider is that because during the early time post World War II, there was an asbestos boom because asbestos was considered a magical substance that can be used for everything. So asbestos was mined extensively in Europe and also in Australia, and also in many other countries like in Russia and in China. And the use of asbestos basically was very extensive during that time, and a lot of people don't understand the risk of asbestos use during that time. So and we know that the lag period, as mentioned by Prof. Marzuki earlier, for the occupational cancer is around 30 to 40 years. So the lag period basically would have increases to this year. So that's why asbestos is high in these countries. But whether in Malaysia, the use of asbestos is that we do use asbestos, but not to that extent, and also we don't have asbestos mine in Malaysia. So our problem might not be asbestos and might be other things. So moving forward, we know that a lot of these heavy industries are moving to light industries, and also we are moving back to office. So the other thing that is on the horizon is shift work. So let us focus on whether shift work actually related to cancer or not, because a lot of people think that shift work can cause cancer, and we will look at some literature, and then at the end we will basically come to a conclusion, or we can discuss further on whether shift work related to cancer. So this one we're going to focus on shift work and cancer. So the next couple of slides, the next part of it, we're going to only talk about shift work and cancer, and then from that, after we'll conclude my part, and I will pass on to Jasima to discuss about her research. That was her PhD research. So shift work, of course, shift work is a method of organization working time in which workers succeed one another at the workplace so that the establishment can operate longer than the normal working hours of an individual. So why we do shift work? There's two reasons why we do shift work. Firstly, we do shift work because the industry demands that we do shift work, because we know that a lot of machineries, when you basically commission them and when you start them, it is more economical to run it 24 hours a day than to run it on a office hour basis. And also a lot of machineries are, the cost of the machineries or the lifetime of the machineries or the efficacy or efficiency of the machineries also come down over the years. So it is much more better to run the machine 24 hours to have the best of the returns of your investment on the machinery. The other reason why we do shift work, of course, is due to the demand of the community, where, like currently, especially in the healthcare industry, shift work is a norm, and everybody needs to do shift work because of the 24-hour nature of our healthcare industry. So that is why shift work is considered a very important occupational hazard. And why is it important? Basically, of course, we have a type of shift work. We can divide into night shift work only, permanent shift, rotating shift, continuous shift, and non-continuous shift work. So which is the best shift work and which is not the best shift work? It is open to discussion, but usually, basically, if you do a rotating shift, if you do a forward shift, or if you do a constant night shift, it's better than a shift work that you basically take more of a rotating shift work. So what are the prevalence of shift work that people in the world? So in few countries, basically they have information on shift work. So in EU, it's 35% of healthcare worker, 34% of plant and machine operators and assembler. As I mentioned earlier, when you talk about machine, you need to be run 24 hours a day to ensure that the return of investment, and hotels and services, and also manufacturing. In the US, hospitality industry, which includes healthcare industry, mining, transport, wholesale, and manufacturing. So these are the major workers in this industry that basically are in shift work. So you look at it between around 30% of the population in this industry basically are engaged in shift work. So it is important for us to look at whether shift work actually causes cancer now. So is there enough research to say that shift work actually causes cancer? All right. So night shift work or shift work has been classified by under IRC 2A, which is basically probable carcinogen, which means that there's limited evidence of carcinogen in human, but sufficient evidence of carcinogen in experimental animal. That's why over the last couple of years or last decade, a lot of research has been done on looking at shift work and cancer, and basically a lot of this using large cohort study to identify whether shift work actually can cause cancer. So how does shift work cause cancer? Shift work cause cancer by looking at suppression of melatonin hormone and also alteration of immune function. We know that melatonin is one of the hormones that is secreted, and the secretion of the melatonin hormone is based on circadian rhythm, and it's also influenced by the natural or ambient lighting around us. So the melatonin is basically a strong antioxidant. It protects the cells from DNA damages and also oncostatic action. So people have the theoretical thing that because of the lack of melatonin and lack of secretion, that is increased in the chances of getting cancer in people working shift work. So example of pathway of shift work causing ill health. So shift work, basically, if you look at it, you can get night shift like here, decrease in melatonin, decrease in clearance of reactive oxygen species, and and that's where it causes heart disease, premature aging, and cancer. It also can be because of the obesity, stroke, and diabetes, which leads to cancer concentration. So the thing is that the decrease in melatonin is the one that we focus on when we want to discuss on cancer. Of course, we know shift work doesn't only cause cancer. Shift work also related to other unhealthy conditions like obesity, stroke, diabetes, because of increase in consumption of eating, and also destruction of the hormonal distribution or circadian rhythm. So what is melatonin? Melatonin is basically secreted from the pineal gland, and sensitized follow the rhythmatic driven by the clock. So when there's light, there's inhibition, and when there's no light, become a stimulation of the production of melatonin. So melatonin basically, and then it depends on the biological clock or our circadian rhythm. First, we focus on the most common discussion among the researcher in the field of shift work and cancer, which is shift work and breast cancer. So I would start my discussion with looking at one of the systematic review and meta-analysis. This is a very recent systematic review analysis done in 2014, looking at 1.4 million women in total, and they look at big studies, basically studies that have 500,000, half a billion, 500,000 population, and million women study, and EPIC Oxford study, and UK Biobank study is 250,000 study. So the total amount of population is basically quite high, and they use this. They look at follow up over the period and see whether the person actually the participant actually develop cancer, and then look at their risk factor, earlier risk factor, to see whether those risk factors are related to develop a cancer in the future. And also they included another 7 previous published study and look at the cohort. So the total number of women in this analysis is 1.4 million. So breast cancer among shift work. So they found that in the million study, out of the 500,000, 673 have breast cancer, and the relative risk is 1. And the relative risk for more than 20 years of night shift work is also 1. Both of them are not significant. In the Oxford study, also is also 1.07, but this is not significant. And the UK Biobank study also is not significant, although there's a reduction in the night shift breast cancer. So the data actually does not what we call argue well that shift work actually, night shift work especially cause breast cancer. So if you look at all night shift work, then looking at the meta-analysis of the 7 study and including the 3 cohort study, you will found that there's no association found between all night shift work and cancer. And even for 20 years night shift work or 30 years night shift work, there's no association found between night shift work and cancer among women, especially if you focus on breast cancer. So the thing is, so the other question is, so if breast cancer, if shift work doesn't cause breast cancer, does shift work cause other kind of cancer? So for the we will discuss this and look at it from perspective. So the second thing we look at, the second study that we're going to discuss on is another study on an updated systematic review and meta-analysis, which is published just last year on shift work and prostate cancer. So a total of 18 studies on shift work and prostate cancer was found, and 12 of it is cohort study and 6 is case control study. And basically shift work and prostate cancer, if you look at rotating night shift, the 17 studies, the odd ratio is just 1.07, and the effect of confidence interval is still not significant. In a cohort study, the odd ratio is 1.03 and also not significant. if we look at only high quality study, that means studies that's been done in considered high quality, the odds ratio actually is lower. It is less than 1, which is basically that means there is considered protective factor, but of course we do all of them are not significant. So studies show that there is no association between shift work and prostate cancer. When you look at the information further, or we digest the information further, look at it, is that all right? So exposure variable, we look at rotating shift work exclusively. The numbers actually, it shows that there are not much what we call, there's not show any association between occupational cancer and shift work. So even subgroup analysis, except for in Asian country, when there's 3 studies that look at pool result is 1.84. This slide we're going to discuss on shift work and skin cancer. So 3.5 million participants participated in this meta-analysis, where they look at 17,000 skin cancer cases. So they found that ever shift, that means ever have exposure to shift work, you have relative risk of, so melanoma, shift work actually causes melanoma, but it basically is protective against basal cell carcinoma and squamous cell carcinoma. So out of the 11 studies that look at melanoma, it found that shift work actually caused melanoma, which is very interesting findings. All right, and further, they actually find a dose-response relationship of the shift work and risk of melanoma. 2% increase in every year of shift work, and you can get means the relative rate 1.02, and that means every year you're exposed to shift work, your risk increased by 0.2% to get melanoma. So it's quite an interesting study. In the study, they did discuss the possible outcome, but they still don't understand what is the rationale, or what's the possible biological possibility of shift work related to skin cancer. So this is my final slide, which is basically looking at type of cancer. All right. So this is the latest research on meta-analysis on many all type of cancer and associated with night shift work and each type of cancer. So if you look at the data itself, there is no evidence actually to show that shift work actually causes breast cancer, prostate cancer, ovarian cancer, pancreatic cancer, colorectal cancer, lung cancer, non-Hodgkin lymphoma, stomach cancer, skin cancer, urinary agent, esophageal cancer, leukemia, uterus cancer, oral cancer, larynx cancer, and testis cancer. So evidence from studies being published have not shown there's a relationship. Of course, we look down at the studies that is other studies. Basically, they have very small studies, and the numbers is very small. So number of studies is very small. The number of participant also is small. So the issue of whether there is the evidence strong or not, we need to consider that. But currently, the evidence available shows that shift work is not related to cancer itself. So we need to reconsider and rethink of the possibility of shift work as a risk for cancer, for breast cancer or for prostate cancer. The information, so the chiral evidence does not show that there is a relationship between shift work and cancer. The relationship between shift work and melanoma needs further studies to identify the possible mechanism, which is basically that is the case. So this comes to the conclusion of my discussion. So basically, the discussion basically focused on, we started off with looking at the number of occupational diseases and injuries that is reported, looking at number of cases that we see in Malaysia, and then comparing that with the number of cases that we see in the UK. And from that we discussed that the number of cases actually, if you remove asbestos as the cause of occupational cancer, the number of cases between UK occupational cancer compared to the cancer in Malaysia is almost similar, which is basically around 18 per year. Ours is around between 6 and 19 per year. So the number of cases of cancer in Malaysia is similar if you remove asbestos. Of course, the issue is how is this a real figure or not? Are we discussing this or not? So maybe we will discuss it further in our forum to see how can we move forward to address this issue of identifying cases of asbestos cancer in Malaysia. Thank you very much. I would hand it back to Prof. Marzuki, so Prof. Marzuki can continue.
Okay, thank you very much, Prof. Victor. Very enlightening presentation. All right, there are a few questions here. We have 10 minutes before we go to the next speaker. There's a question from Dr. Zainul, Prof. Victor. ILO and WHO have implemented global silicosis elimination program, and silica is a carcinogen, it's one of the carcinogen. Where can Malaysia implement it? When can Malaysia implement it in terms of elimination of this silica use, as this is the second to asbestos for occupational cancer? So can we do that?
Basically, silica, all right. So silica is actually very difficult to eliminate silica, but we can eliminate the use of silica in industry processes. But to eliminate silica itself is quite difficult, because you know that the world, I think 18% of the world crust and 80% of the world minerals are actually silica, and we use silica for many processes, including the manufacturing of semiconductor, building houses, and also for construction of other materials. So we can use to eliminate using silica in processes like sandblasting, and we can use other materials to do sandblasting. That is possible, but for us to remove silica itself from as a hazard is basically not possible. But the only possibility is to remove it as a process itself. Most of it is basically on sandblasting, and that Malaysia has been doing. Basically, if you do sandblasting, you need to be registered and need to be licensed to do sandblasting. We cannot eliminate silica from building materials. We cannot eliminate silica from especially because silica is sand, and sand is one of the key building materials that we have, and that cannot be eliminated. And when you are handling sand itself, there's not a problem. But if you're handling sand and you are basically using high-speed machinery to handle sand itself, basically that will cause generation of dust, and this dust basically are dangerous because it's a respirable dust of silica. And as I mentioned before, there's currently an epidemic of silicosis in Australia and also in Italy, which focus on the manufactured hardtop for kitchen hardtop. The main thing is the understanding of how to handle silica and how to use silica. So to remove silica itself is not possible. I think that Dr. Zainul, I hope that answers your question.
Okay, thank you very much. Can you unshare your slide first before I go to the second question, Victor? All right, second question by Dr. Sina. It's kind of difficult to differentiate the cause, like the cause of cancer itself, whether it is from asbestos, from diesel engine exhaust. So if we find one cancer cases, how to differentiate the cause of that cancer itself?
Okay, so the idea is how do we attribute the cause of cancer to whether it is due to asbestos or due to this exhaust fume. Firstly, we must take a good occupational history, all right, and to see whether there is risk of exposure to asbestos or to this exhaust fume. So of course, asbestos and this exhaust fume basically will cause lung cancer, all right, and for that to happen, the respiratory physician might be able to ask a more in-depth what we call question or in-depth occupational history on whether there is cancer. It is difficult because it is difficult to just say that there is a sign that this is cancer, but it is we do give benefit of the doubt when we say that the person is actually exposed to asbestos and he developed cancer, and basically we can say that this is asbestos cancer. Of course, we can do what we call biopsy to see whether there's asbestos particles inside or not to cause cancer, but that is a secondary thing. But if you're exposed to asbestos, then we can say that you can most probably it's asbestos cancer. Of course, in Malaysia, if you want to use asbestos or you want to process asbestos, you need to be licensed to process asbestos and also to use asbestos, and licensing actually says that you need to do annual medical surveillance. So the occupational doctor basically dealing with these workers to do annual medical surveillance should have the high index of suspicion to basically rule out cancer. This is same for silica also. As if you are using silica as a process, you need to what we call need to do medical surveillance. But of course, some of the processes that we use, we don't consider it silica as a process, but silica as a byproduct. So when silica is a byproduct of the process you are doing, or silica dust is a byproduct of the process you are doing, then it has become a problem because that is not regulated under our FMA mineral dust regulation. So mineral dust regulation only says that we use silica as in the process, but not as a byproduct. Basically, when we most of the issues basically from a byproduct of silica. And I think we can discuss this further later in the forum of how do we differentiate between the occupational cause and non-occupational cause.
Okay. Maybe last question, Victor, before we move on, by Muhammad Izzuddin. He said nowadays there's more babies or young children have cancer, and can we assume that because of exposure of their parents towards cancer agent at workplace and not simply due to the inherited genetic?
This is a very interesting discussion, and I cannot give you the answer because I have not done research on this to answer you on that. We can assume if we can identify that there is a carcinogen that the parents is actually exposed to, that can be related to the exposure to cancer. But of course, we also can look at it from the environmental perspective, not just the genetics perspective, that the exposure might be due to environmental issue. So the other thing is whether the parents basically pass down a genetically different gene to the kid because of exposure to hazard in the workplace. That also we need further research, and I have not done that, so I wouldn't be able to answer that question to you. Thank you. It's a very interesting question. Maybe we ask other presenter whether they can answer the question.
Okay, thank you very much, Prof. Victor. Actually, there's a lot more other questions. We will ask all these questions during our forum session at 12 p.m. after all the presenter has presented their lecture. So thank you very much, Prof. Victor. We'll move on to our second speaker. All right. Apparently, we have to do some changes here. Dr. Wong Chi Kwan will be speaking first on lung cancer, and then after that only will be followed by Dr. Jasima. Dr. Wong Chi Kwan is our respiratory physician from University of Malaya Medical Center, Respiratory Medicine Unit in University of Malaya Medical Center. He's the reference person, especially in Malaysia with regards to respiratory medicine and also in tuberculosis. Without further ado, I'd like to invite Dr. Wong Chi Kwan to present his lecture. Dr. Wong.
Hi, good morning, Prof. Marzuki and also Prof. Victor and everyone. Thank you, Prof. Marzuki, for the kind introduction, and thank you for inviting me to join this important and also special webinar on occupational cancer in Malaysia. I will actually talk more on regards on what is the overall overview of the lung cancer and its screening and also its management, not particularly concentrating on mesothelioma, because I suppose in Malaysia we don't have a very big data in regards on mesothelioma, and personally myself, I have not been managing so many malignant mesothelioma cases. So far, I've seen about 3 cases throughout my what you call practice in University Malaya Medical Center. Okay, and it's not very easy. It's not easy to diagnose malignant mesothelioma. And okay, without further ado, I would like to start my talk. Okay, this is the content of my lecture. I will first of all introduce to you what is lung cancer and its burden, and what are the potential risk factors of developing lung cancer, and how do we classify lung cancer histologically, and what are the clinical features of a lung cancer patient, and how do we diagnose lung cancer, and how we assess them after the diagnosis. Important is to stage the patients and decide on the further treatment modalities. And definitely, I will touch a bit on the lung cancer screening in patients with a high risk of developing lung cancer. Okay, so for based on the WHO incidence of cancers worldwide, they found that lung cancer is still the most common cancer worldwide, accounting 11.6%. Together with breast cancer, and followed by colorectal, prostate, and stomach cancer. However, the survival for lung cancer is lower as compared to the rest of the common cancers worldwide, because the early detection of lung cancer is difficult. Majority of the lung cancer patients do not have symptoms, not like patients with breast cancer that they can actually do self detections. As for colon cancer and also gastric cancer, they have surveillance in detecting a nodule, except low dose CT scans. Therefore, a lot of time, lung cancer presented to us in a very later stage, therefore causing them to have a poorer prognosis. And in this, what you call WHO worldwide incidence of mortality for lung cancer, it accounts about 18.4% of the total mortality for cancers. What about in Malaysia? In Malaysia itself, based on the Malaysian National Cancer Registry report done from 2007 to 2011, they found that out of these 100,000 patients with cancer, lung cancer is believed to be the 3rd commonest cause of the cancer, accounting about 10.2% of the total cancer. And a majority of them present very late, as you can see in this cartoon. It shows that male and female both actually they present in a very later stage, stage 3 and 4, whereby about 90% of them presented at this advanced stage. And this is an important graph, Kaplan-Meier graph, to show the prognosis of a lung cancer patients. If let's say they are detected early, for instance, when they are detected at the stage 1A and 1B, their prognosis at 2 years is about 90 to 97%, whereby at 5 years survival can go up to 92%. However, if let's say a patient is diagnosed to have advanced lung cancer, which is stage 3B and above, the mortality, the survival for the 5-year survival would be very low as 26% or nil. So therefore, it is important for early detection of lung cancer and to manage and aim for cure. In Malaysia, majority of them, as what I mentioned just now, presented late stage, and the 5-year survival rate for advanced stage for Malaysia would be 6.3%. And what are the potential and common risk factors of developing lung cancers? Not just occupational exposure, but there's other important factors that we need to look into. So the important factors that causes lung cancer would be genetic risk factors, tobacco, diet, and alcohol, chronic inflammations from infections and other medical conditions, ionizing radiations, occupational exposures, air pollutions, and other risk factors such as hormonal involvement or effect from the female hormones. Okay, for the genetic risk factor, it is found that there's an important locus in the chromosome 6q23 to 25 that actually causes a family to have a higher risk of developing cancers. And also there's a syndrome called Lee-Fromeni syndrome, whereby it is an autosomal dominant condition that increases the risk of cancer for like breast cancer or bone cancers or in fact adrenal cancers. And this actually also increases the risk of lung cancers. And it is also due to multiple genetic polymorphism that causes the lung cancers. And by using a system or a way of identifying this common genetic variation, which is the single nucleotide polymorphism, they found that there are 3 important loci that is causing the increased risk of lung cancer, which is 15q25, 5q21 region. Smoking is still the most important risk factor for development of lung cancer. And as you know, there are a lot of patients who actually develop lung cancer out of a secondhand smoke, whereby out of that 20 to 30% of them has an increasing risk of developing lung cancer with a secondhand smoke. And a smoker has actually 20 to 50 times higher risk of developing lung cancer as compared to cigarettes. Is important to increase the risk of lung cancer. And surprisingly, if you actually stop smoking, and this actually will decreases the risk of a lung cancer to about up to 90% in certain studies. This graph is showing the prevalence of tobacco smoking in Asian country, and as you can see, Indonesia has a very high prevalence of tobacco smoking among the males, whereby 76.2% of the male populations are smokers. In Malaysia, we are also doing quite badly in the terms of prevalence of tobacco smoking, whereby 43% of the male populations actually are smokers. And this is major issues in tackling in Malaysia, whereby smoking cessation service or clinic is not well established, and tackling this issue is important in prevention of lung cancer. Why smoking causes lung cancer? Because there are so many carcinogens in the tobacco smokes. Okay, the carcinogens that has been identified in the tobacco cigarettes are polycyclic
Your line is interrupted, Wong.
carbon.
Sorry, we can't hear you clearly.
Nitrosamines, aromatic amines. Pazuki, can you hear me?
Now better. Can you repeat on that slides?
On the summary of carcinogen, is it?
Oh, yes.
Okay, sorry about the technical issue. I still have not get back my power supply. Okay, so right, so the summary of carcinogens in the cigarette smokes. Well, it is like important to know that cigarette smoke causes lung cancer because of various carcinogens, which is in our cigarette smoke, tobacco smoke. They are polycyclic aromatic hydrocarbons, azarines, nitrosamines, aromatic amines, heterocyclic aromatic amines, aldehydes, and other organic or inorganic compounds. Okay, so this cartoon is just showing what happened when a person smokes. All right, so there will be a lot of these carcinogens that actually will need to go through the cytochrome P450 enzymes and get oxygenated and become a metabolite. And this metabolite actually can be excreted from the body if ever the body able to detoxify it using the metabolic detoxification pathway. However, some of those metabolites who's unable to be detoxified will go into the metabolic activation pathway. So this will react with the DNA and also with the macromolecule, and they combine and bind together and become a substance called adducts. And with this, if the body is able to repair, it will become to a normal DNA. But however, when it's unable to repair and is causing miscoding persistently, it will actually causes what you call a lung cancer. All right. Some of those cells which is miscoded can actually develop apoptosis, and they may actually do not progress into a lung cancer. So it is very damaging for smoking. And what about diet and alcohol? Diet is that is rich in vegetables and fruit, especially the cruciferous vegetables, actually have a lot of protective effect against lung cancer. And studies have shown that high intake of meat with those like fried or well done red meat can actually increase the risk of lung cancer, because this actually form nitrosamine, which is a carcinogen during cooking. And we're not so sure whether the person who actually cooks, like the ladies who actually stay in the house and cook, that actually has exposed to these carcinogens while cooking and causing them to have a higher risk of developing lung cancer. And of course, high intake of fat or saturated fat will definitely increase the risk of lung cancer. There's also studies shows that it is a higher risk of developing cancer, lung cancer in the alcoholics after they have adjusted the smoking history. So what type of chronic inflammations or infections in the lung that actually can increase the risk of lung cancer? So obviously, pulmonary tuberculosis is a form of a chronic infection, and it has been found to increase the risk of a lung cancer. And it's actually increased the risk of 1.5 to 2 times after the diagnosis of a tuberculosis to develop a lung cancer. And as for ionizing radiation, it has been proven that it will increase the risk of a lung cancer, and patients who actually treated with radiotherapy with the cumulative exposure of 100 gray will also increase the risk of developing lung cancer. And it's also shown that the underground miners who was exposed to the radioactive radons and its decay products with also increased the risk of lung cancer by 6% per working level year of exposure. So there's two important studies. One is in UK and the other one is in France that shows that occupational exposure can actually cause a lung cancer. So the total lung cancer that actually causes by occupational exposure would be roughly about 12 to 14.5%. And the important causes or carcinogens that they identified are asbestos, silica, radon, heavy metals, polycyclic aromatic hydrocarbons. Okay, so those people who actually works in the installations and shipyards will have higher risk of exposure to asbestos, and the risk of a lung cancer after 10 years of exposure will be very high, and it increases up to 90-fold if, let's say, the patients concurrently smoke. And again, it shows that not just the carcinogens increase the risk, but smoking plus the carcinogens or the occupational exposure triple or even increase the fold of lung cancer development. Other occupational carcinogens such as arsenic, nickels, radiation, hematite minings, hard rock minings, chloromethyls, ethers and mustard gas, and soot and tars will also increase the risk of a lung cancer. So there's one important study that I would like to share, which was done in Europe. It's a multi-center case control study whereby they involved 7 countries, and they look at those patients with lung cancer. They try to link the possibility of developing lung cancer with the exposure of a known high-risk carcinogens and also suspected high-risk carcinogens. And they found that it did not play a major role in the lung cancer risk among the never smokers. Okay, so but they found non-ferrous metal dust and fumes and silica may exert a carcinogenic effect, and they would suggest to do more studies on particular female patients. So majority of the cases that develop lung cancer in this cohort are female patients, and also they are non-smokers. So there's an increased reason why we need to find out female never smoker tends to have higher risk of developing cancer, and whether is it due to occupational or not, it has to be answered in future. So how do we classify lung cancer? Lung cancer can be classified based on the histology. Okay? The common classification would be small cell or non-small cell carcinoma. All right. So this is based on histology, the morphology of the cancer. How does it look like? All right. So for small cell, roughly about 10 to 15% of the total lung cancer, and whereby for non-small cell is comprises of 85 to 90% of the total lung cancer cases. So in non-small cell, the commonest we have would be adenocarcinoma, large cell carcinoma and squamous cell carcinoma. The less common carcinomas would be carcinoid tumors, carcinomas of salivary gland types, carcinomas with pleomorphic sarcomatoid or sarcomatous elements. And the classification of this lung cancer is based on the WHO classification 2015 by using the H&E or the mucin stain, the immunohistochemistry stain, genetic profiling, and also radiology diagnosis. So in the past, for lung cancer, they have to use a big chunk of tissue to identify which type of cancer, whereby nowadays we use a very small tissue biopsy that we can actually do further staining and confirm the histology type of the cancer. So this is how it happens at the moment, right? For the non-small cell lung cancer, which is the most common type of lung cancer, the more common would be the adenocarcinoma, which comprise about 50% of the total non-small cell lung CA, and about 30% of them will be the squamous cell carcinoma. And we will do molecular testing among all these non-small cell lung carcinoma, and to find out which are the potential targeted therapy that we can use to treat this kind of cancer. Okay, so the most advanced development at the moment would be the adenocarcinoma subtype, whereby about 15% of them is found to have EGFR mutation, 30% will be a KRAS mutation, 5% ALK mutations, and the rest are less common mutations. So far, there are hundreds of mutations has been identified, but the potential available treatment at the moment, in fact, in Malaysia itself, would be the EGFR and also the ALK, the MET inhibitors, the HER2 and the ROS1 inhibitors treatment. Whereby for squamous cell carcinoma, there are a lot of other mutations, right? But most of them, at the moment, we do not have a specific treatment, but majority of them will still require chemotherapy therapy. Okay, so this is a cartoon just showing the mutations that's available in the adenocarcinoma type and also the squamous cell carcinoma type. So what are the clinical features of lung cancer patients? Majority of them will actually present with chronic cough, hemoptysis, weight loss, anorexia, difficulty in breathing, facial swelling, and neck swelling. So in cases with superior vena cava obstruction, you'll see the patient will have a bloated face and dilated chest wall veins. And after stenting of the SPC, you noted that the patient's swelling has all resolved. And the patient might present with Horner syndrome, whereby there's a cervical sympathetic chain is compressed in the apex of the lung. And some of them will be present with asymptomatic X-ray, shows that the patient has a hilar nodes, a hilar mass, and when we biopsy the mass, it turns out to be squamous cell carcinoma. And also we may see patients who come in with pleural effusion, and when we actually biopsy the pleura, we noted that this kind of patient has adenocarcinoma. So when there's a central lesion, it's likely to be squamous cell or small cell carcinoma, whereby if it's a peripheral lesion, it's more likely to be adenocarcinoma. But however, it can happen in the other way around. Particularly the adenocarcinoma may also present as a central lesion. Okay, how do we diagnose and assess the lung cancer patients? So diagnosis and assessment of lung cancer is very, very complicated and extensive. So you need to get a full medical history, and you need to examine the patient, and followed by getting a chest X-ray done to see any obvious masses or also effusion. If you can't, then a CT scan of the thorax will be crucial and essential to look for the mass. All right. And if, let's say, there's detection of the tumor in the CT or the X-ray, the patient may be referred to the chest physicians, oncologists, or even the cardiothoracic surgeon. Majority of the cases will be referred to chest physician or cardiothoracic surgeon for further evaluations. And we don't just stop there. So we may actually, we will have to do further imaging, for instance, more precise CT scans, contrasted CT scans, or even PET or positron emission tomography or CT scan, and also MRI of the brain. So this is particularly important in staging of the disease. And we will have to confirm the diagnosis by doing a biopsy, a tissue biopsy from the lung or from the mediastinal lymph node. And getting a biopsy is not just one method. There's multiple modalities, and depends on how complicated and how difficult it is to get the biopsy done. So majority will actually get a CT guided needle lung biopsy, and if, let's say, it's a central lesion, the pulmonologist or the chest physician will actually do a bronchoscopy biopsy, or they can do needle aspirations of the mediastinal lymph node. And if, let's say, all this cannot yield any diagnosis at all, the patient may have to go for thoracoscopy by video-assisted thoracoscopic surgery. And nowadays we have endobronchial ultrasound that actually can see the locations, the exact locations of the tumor in the central airway, and we actually can use the ultrasound to guide us on doing the biopsy. Same as endoscopic ultrasound. And as for mediastinoscopy, will be the last resort if ever we can't yield any diagnosis out of the above semi-invasive procedure. Okay, once we do this, we will actually have to send the biopsy specimen to the pathologist for them to actually read whether and diagnose whether it's a non-small cell or small cell carcinoma. All right, and not just that, we will have to send for further biomarker testing, particularly on those important biomarkers with targeted therapy, which are EGFR, ALK, ROS1, PD-L1, and etc. All right, so after we assess the patients and we actually stage the patient accurately, we will need to actually decide whether the patient is fit to undergo the therapy or the treatment. For instance, curative surgical therapy, radiotherapy, or even chemotherapy. So we have to assess their pulmonary function, their heart, by doing the ECG and echocardiogram, and so we need to look at their blood, particularly the renal functions and the liver functions. And then everyone will have to sit down and talk and discuss on the patient's treatment modalities in a multidisciplinary team management meeting. And this will comprises of surgeon, radiotherapists, chemotherapists, also chest physicians, oncologists, and chemo nurses. All right. And after treatment, you have to actually do surveillance for the patient for at least 5 years, particularly doing CT scan and PET scans. Okay, so the doctors they are involved in all these stages is shown in this what you call slides. And you can see one person cannot manage the lung cancer. It is a very long journey. As you can see, it can take up to 2 weeks, up to 1 month to just get a definite diagnosis done and to start on the treatment treatment that improve the outcome of the lung cancer. All right. So how do we stage? As what I've mentioned, so we look at the mediastinal lymph node. Okay, we have so many zones. We have the supraclavicular zone, we have the upper zone lymph node, we have the aortic pulmonary zone lymph nodes. We also have the subcarinal nodes and lower zone nodes, and we have the hilar and the peripheral zone lymph nodes. Okay, so all these nodes is important to be staged and to be identified, as a different node involvement will change the staging of the condition. So the staging that we use is the TNM staging 8 edition, and it's a very comprehensive staging. It stages the patient from stage 1A, 1B, 2A, 2B, 3A, 3B, 3C, and up to stage 4. Okay, so we have 4A and 4B. All right. So all this depends on the involvement of the tumor size, how big is the tumor, and where's the site of the tumor. And number 2, we look at how many lymph node zone is involved, whether it's the lower lymph node zone or the higher lymph node zones are involved, and also whether is there any metastasis to a local or to the distant lung, or to the pleura, or to a pericardium, and also to the distant metastasis. So again, I'm showing this slide is because if you stage the patients accurately and precisely, you can actually improve their survival, their 5-year survival. If you stage them wrongly and you actually did not offer them curative surgery or chemoradiation therapy, the patient's staging, the patient will have a poorer prognosis. Okay, so the aim of the therapy for lung cancer is curative therapy, but however, if let's say we can't aim for the palliative therapy, we can actually go for targeted therapy. So in the past 1970s, nothing much we can offer for the patients. We only can offer surgery or radiation therapy. In 1980s, there's development of chemotherapy, but however, majority of the patient may only survive up to 5 to 6 months after chemotherapy. And the chemotherapy that used is full of potential bone marrow suppressions and causes an increase in adverse event. And in 1990s, to further improve the survival of a patient, they started to combine different forms of chemotherapy to increase the patient's survival. And in the 2000s, we have started to develop targeted therapies, particularly on the looking at the different forms of mutations, and we use a different targeted therapy to treat different advanced stage of lung cancer. And also they have put both targeted therapy and also chemotherapy together to increase the further survival. And now at present, we are using the next generation targeted therapy and also the immunotherapy to further improve the survival of the lung cancer. So as you can see, the evolution of the treatment actually has come very fast in the year 2000 and beyond. Okay, so we are not just identifying the patients having a non-small cell lung cancer. We are actually subdividing them into non-squamous and squamous, and we further do the molecular testing, and we actually give a proper targeted therapy according to the oncogenic drivers. Right? And management of lung cancer, again, it requires a multidisciplinary team. So the respiratory physicians, together with the oncologists, cardiothoracic surgeons, pathologists, and radiologists actually sit down once in a while to discuss complicated cases. Like in UMMC, we actually started this service in last year, July, and we have not last year, 2019 July, we have started this service, and we have discussed numerous complicated and complex cases, and we have come into a consensus on how to manage patients. And further, definitely some of those patients who are unable to receive any curative therapy and patient actually opted for palliation, we will actually refer patients for palliative care. And we also need our specialized lung cancer nurse to actually help us to manage all these lung cancer patients. So this is actually important to provide an environment that is able to have a continuing education for all the members in the committee and also for our junior doctors. And it is to ensure that we are complying to evidence-based guidelines and to manage the patients accordingly. And this will actually improve the efficiency of communications and coordinations when making decisions in cancer treatment. Okay, I apologize for this busy slide, but this is how complicated it is when we want to decide for treatment for a patient, right? And this is just for non-small cell lung cancer patients. If let's say we stage them clinically into stage 1 or 2, we will have to decide whether the patient can go for surgical curation, okay? And it depends on whether the patient's performance status are good. If let's say they are good performance status, we will actually send them for surgical resection and plus adjuvant chemotherapy or radiotherapy, and the patient will go for surveillance. But if let's say the patient is not a surgical candidate, we can actually offer them CyberKnife or definite radiotherapy and followed with a surveillance therapy. As for clinical stage 3, as what I mentioned, the multidisciplinary team approach is more important because it is a gray area, and we need to actually decide whether the patient can go for curative treatment with surgery, chemoradiotherapy, or chemoradiotherapy with immunotherapy. And we can actually follow with a surveillance therapy. As for advanced stage, who actually not deemed for surgical curation, we will depend on whether they are squamous or non-squamous, and we will have to do further molecular testing and PD-L1 testing, and we can decide for immunotherapy or immunotherapy plus chemotherapy for squamous. And if let's say they have targeted therapy that can be used, we'll use a tyrosine kinase inhibitor to actually manage the advanced stage of cancer. If ever the patient do not have any targeted oncogenic driver mutation, so they will have to go for immunotherapy or chemotherapy alone. And I'm not going to go through the small cell lung cancer. It's also similar, complicated, and it also comprises of a lot of discussion with the oncologist and also the surgeon, whether they can go for surgery, chemotherapy, or chemotherapy alone. Okay, so I'm going to talk about lung cancer screening, which is a very important aspect in preventing a development of an advanced stage of lung cancer, because the earlier you detected the nodule, you biopsy it and you resect it, and you will have a curation of the lung cancer. Okay, so how do we screen lung cancer patients? The most important modality is by using a low-dose CT scan of the thorax, and we suggest to do it for patients with a smoker of 30 packs and above, or after 15 years of after the cessation, with the age of 55 years to 74 years old. Okay, so anyone more than 75 years old, that will be depends on whether they have a good performance status. All right, some of those patients with a poor performance status and not willing to be screened, we will not actually force. Okay, but majority of the patients that we need to screen is by the age of 55 and above, who are heavy smokers, and because we can actually increase the detection rate and also increase the cure of lung cancer in these kind of patients. All right. So other methods of like screening, such as X-ray, sputum, and biochemicals, are not recommended. The biochemicals will be the tumor markers. Some of the time it will be raised, and a lot of times by using the tumor markers, a lot of people actually gone through a CT scan and they incidental found to have tumors. But this is not the preferred way of screening for patients. The most important and the preferred way of screening will still be low-dose CT scan. And again, how do we work out for the diagnosis and staging? Similarly, as what I've shown in the journey of a lung cancer patient, the patient had to go through a general medical history, physical examination, assessment of their comorbidity and their performance status, and we have to go for CT scans and PET scans and MRI brains, and we have to check their blood tests, and we have to assess their functional status, and of course we have to do a biopsy to get the tissue diagnosis. And as you can see, it's not cheap. You have to do a lot of investigation just to make sure that the patient is staged accurately, and therefore screening for lung cancer can cost a lot. All right, but the good thing is the patient will be cured and will not have to subject for advanced therapy treatment, which also an expensive form of therapy. Why I say that is because the treatment for advanced stage of disease requiring targeted therapies such as tyrosine kinase inhibitor can cost about 5,000 a month. All right, and the more expensive can go up to 30,000 per month. As for immunotherapy, one cycle can cost the patients about 16,000 per month, 16,000 to 20,000 per month. Yeah, so it is a rather expensive therapy, but it's an effective therapy. So to prevent that, so an early diagnosis of a malignant tumor and resected tumor with adjuvant chemo and radiotherapy to actually avoid a long-term therapy for advanced stage of a cancer therapy. So this is my last slide. So the summary for lung cancer is still the leading cause of death for overall cancer, and majority of the lung cancer present with advanced stage, and smoking is still the leading cause of lung cancer. So managing lung cancer is very complex and expensive, and it requires a multidisciplinary approach. And occupational exposure in lung cancer may be underreported in Malaysia. So this is also very difficult to ascertain in patients with history of smoking, as there's a high prevalence of smoking in our country. So we need more studies to be done in Malaysia to ascertain the occupational exposure and the causative to the lung cancer. So therefore, lung cancer has to be detected early, and this will actually lead to a better prognosis of the lung cancer patient. Thank you.
Okay, thank you very much, Dr. Wong. We shall continue with our next speaker. With us today, we have Dr. Jasima Begum. Dr. Jasima is the Public Health Medicine Specialist, Ministry of Health, Malaysia. Currently, she's in charge of CPRC for COVID-19 in Putrajaya. She's a very busy person now with the rising cases of COVID-19 in Malaysia. She's the one who are preparing, I guess, the press statement for DG from CPRC in Putrajaya. She's graduated in University of Malaya with her DRPH in Occupational Health. She was working with DOSH some time ago for quite a period of time, and she has vast experience in managing occupational health cases and also occupational medicine cases in UMMC. Without further ado, I'd like to invite Dr. Jasima.
A very good morning, everyone. I'm so sorry because I was having a bit of issues with my system and connections, and it took me a bit of time to log in, and we had to swap the slots. So I will be presenting regarding occupational carcinogen exposure. And thank you, Dr. Marzuki, for the very kind introduction. Allow me to just introduce myself a little bit. For those who don't know me, I'm Dr. Jasima. I'm currently serving with the Crisis Preparedness and Command Center at Ministry of Health, Malaysia. I'm actually in charge of clusters for COVID-19 for the country. And prior to this, I did my studies, Masters of Public Health in University of Malaya, and subsequently continued with my doctorate in public health in UM as well. So Dr. Marzuki is actually my supervisor, and Prof. Victor is my lecturer and guide as always. And one of the main areas that I focused through for my studies were on occupational carcinogen exposure and burden of occupational cancer within the country. All right, okay, so now I will be speaking and sharing a bit regarding the occupational carcinogen exposure, and I will be giving a bit of introduction, the background of these exposures, and subsequently I will highlight what is being done within the country, meaning in Malaysia, regarding these exposures. So allow me to start, and for this presentation I would like to acknowledge Dr. Marzuki, Prof. Nirmala, Prof. Victor, and Dr. Azlan Darus. Dr. Marzuki, Prof. Nirmala and Prof. Victor is actually from University of Malaya, as we all know, and Dr. Azlan Darus is from Social Security Organization. Now, part of my study mainly used up data from SOCSO, their health screening profile data, that we explored further to look into exposures to carcinogen factors among these employees. So basically it's a very vast database, but we managed to have a good cooperation from SOCSO and extract the data to look into exposures among Malaysian employees. So I'm very thankful to UM, and I'm very thankful to SOCSO for allowing us to look into their information and further explore on this subject. So allow me to start a bit regarding what is meant by occupational exposure and all that. For those of you, I'm sure today we have participants from various groups, including occupational health doctors, experts, and also medical practitioners. So let me start from the basic a bit, and we can go in further into other details later. When we're talking about occupational exposures, it means that there's presence of substance in the work environment external to the subject. And as we all know, the core bread and butter of occupational health is made up of understanding the hazards. And these hazards are physical hazards, chemical hazards, biological, ergonomic, and psychological agents. Examples of physical hazards like noise, vibration, radiation, lighting. Biological like bacteria, fungi, and ergonomic aspects are like risk factors that comes with manual handling, repetitive movement, restrictive work area, and so on. And then we have chemical exposures at work, meaning that substances that are chemical based but can present in various forms, for example, like fumes, gases, aerosols, mist vapors, and liquids. And when we are talking about exposures, it means that these exposures are something that is above the limit or normal level that is being set from the background level. So when we're talking about background levels, where do we get these measurements? These are basically from studies that have been carried out throughout the years, information that were regularly updated, for example, by the American College of Government Industrial Hygienists, ACGIH, and then in Malaysia, we have our regulations under DOSH and the UISH regulations that is also being currently updated. So they have set what are the background levels based on the available informations, and we refer to these particular values when we are saying that there is going to be an exposure more than the limit being set. So this is something that we are looking at objectively, and when we are saying exposure, again, it means that it is more than what is being accepted as tolerable. And having said that, there are certain types of exposures that cannot be very objectively measured. As for example, when you're talking about job stress or when you're talking about certain ergonomical hazards and so on, it has to be from a questionnaire basis or from a subjective approach. But definitely from a scientific point of view, we will be using validated measures and tools to quantify and to mention that these exposures are indeed hazardous to the employees. Okay, so when we are also talking about exposure, we cannot run away from the term of risk. Risk is, as we all know, the formula is hazards times exposure. And there's another element that many academicians have looked into, which is the vulnerability, meaning or the likelihood of these exposures being present, and how much, although the exposure can be very high, but how frequent and how vulnerable are a group of people who are being exposed to these hazards are at risk of developing a certain type of occupational disease. So this is the basic formula, and based on this risk, we come up with the next level of action, which is the control measures. So when you're talking about control measures, again, the most basic is we have to understand the hierarchy of control. So why am I emphasizing from the very beginning about the basic things that some of you may already know and very well versed about is because if you don't get the grasp of this, then it will be very difficult to follow my presentation. So let me start. When you're talking about hierarchy of controls, we're talking about 5 stages. So it's actually an inverted pyramid, meaning that when there's a risk or a hazard and people are being exposed, the best method that we can do is to eliminate. But having said that, not all the substances or work process can be totally eliminated, meaning we physically remove the hazard from the workplace. And the next action would be to substitute, meaning we replace the hazard with something less hazardous. All right. And if that is not possible or cannot be supported with any other control measures, then we can also implement the engineering controls. So let me also highlight that in certain work situations or work processes, not only one particular control measure exists, it can be a combination of many types of control measures. So when talking about engineering controls, it means that we come up with processes or engineering measures, control measures, that we look at the source of the hazard producing source. For example, like noise. When we're talking about noise, we have source reduction, meaning that we modify the machine or so on to reduce the noise exposure. So I'm just giving some analogies for you to understand and grasp what is this hierarchy of control is all about. And other than this, we can also implement administrative controls, which means we change the way people work. For example, we have job rotation, limited work hours, and covered areas, and only authorized personnel to enter a certain area for a limited amount of time, and so on. These are the administrative controls, and also to logistically procure and make available PPEs is also a part of administrative control. And the last in this hierarchy is, of course, the personal protective equipment. I think when we are talking about COVID currently, we are not PPE is something so common that it's on our daily vocabulary at the moment, especially us in the medical field and so on. So PPE, although it is there in the hierarchy of control, as we realize it's at the lowest part of the hierarchy of control, meaning that if you look from a regulation point of view or scientific point of view, it means that other control measures must be there to go hand in hand with availability of PPE. So PPE alone is not sufficient to reduce any form of exposure. And at the same time, PPE is also being used while other control measures are being effectively implemented. So having said that, how effective is effective? That's another question that we have to think about and answer appropriately. All right. So let me start with what is meant by exposure. So exposure assessment, it has many ways of doing it, and it has tools and approaches. As I mentioned earlier, it can be objectively measured, and it can also be subjectively handled, depending on many other aspects like time limitation, what are the opportunities, how big is your project going to be, and what type of industry or workplaces are we doing it, how much of budget we have, and so on. As for example, if you're dealing with a large manufacturing company, then you will be, of course, you'll be having the logistics and the budget required to do a very vast or extensive exposure assessment, hiring the appropriate personnel and so on. And at the same time, you will be also seeing small and medium enterprises with limited budget, but the assessment process has to be carried out. So many factors actually influence what sort of exposure assessment that we would like to carry on. So why is exposure assessment being performed? It's being performed to estimate the risk of an employee being exposed to the occupational hazard, or the risk of an employee or employees to develop occupational hazards. So this is the basic of it. And as I mentioned earlier, what is meant by risk? It is meant by probability of developing adverse health effects due to exposure to hazardous substances. So risk is hazards times exposure. So this risk and health effects, the health effects actually can range from subtle changes within the human system, or even can be come up with serious consequences like death and so on. And another thing that we have to remember here is when we're talking about exposures at work, these exposures can also happen out of the work environment. For example, when we're talking about, let's say, chemicals, paint, and so on. So let's say the person has some other hobby like painting at home or doing it extensively out. Let's say it's a graffiti artist and so on. So being exposed at work is one thing. So him painting out of work is another thing. So these are the things that us as occupational health practitioners or medical practitioners have to ask in detail and find out what are they being exposed to, whether it's at work or non-work related. So why is it important? Another thing is we need to quantify how much of exposure actually happened from work. Is it compensable for occupational health related diseases? And is it truly caused by work exposure? If yes, what else need to be done at the workplace to control the risk for other employees as well? And then this comes to highlighting another factor, which is occurrence of cancer clusters at the workplace. So meaning that a few people at the workplace develop a similar type of cancer, then a certain doubt will rise. What is the actual risk that is actual hazard that these workers are being exposed to at that workplace? So we need to explore that further. So it's actually like a big puzzle that we have to put the pieces together to identify what is the exposure like, what is the risk like, and who are more vulnerable to develop the disease. So if we put these pieces together, then we will understand. So this is the particular reason why I started with the very basic for you all to understand what is meant by risk, what is meant by hazard, what is meant by exposure. So next, the basic of this another factor is we are looking into how this hazard identification, risk assessment and risk control is being done. So it is not an individual process, it is a collective process, meaning that it is being done by the employer and also input from the workers themselves. So based on that, after understanding what are the work activities that are being carried out and in consultation with the employees and also the employers' representatives, the hazards are being identified. So once the hazards are being identified, the risk assessment is being carried out. As I mentioned earlier, it depends on the place, availability, current regulations, legislations in place and so on. So after the risk assessment is being done, then we come up with a risk control plan. And the risk control plan will identify what are the actions that can be implemented appropriately. So we don't stop at that. After the actions are being implemented, then it has to be reviewed to see how effective the actions are working or reducing the risk for the workers. So this is actually a very stepwise approach, a very basic approach, but it has a lot of input required to come up with this stepwise action. And once that is done, it is hoped that the risk can be characterized appropriately and control measures can be implemented. And it has to be very much tailored to the specific work setting, as exposure will differ from one workplace to another. So this is the basics of understanding exposure. And for you to understand occupational carcinogen exposure, the same methodology applies. So we have to go with understanding the risk, subsequently understanding the risk assessment, and then identifying the hazards, which we are going to talk about in detail later, the occupational carcinogens. Okay, so now what is meant by occupational carcinogens? As you can see on the slide here, occupational carcinogens are actually substances, radionuclide or radiation, that act as agents directly involved in causing cancer and must come into contact with the human body through environment in the workplace. So we have carcinogens, that first part of the definition, and for the second part of the definition and the first part, the occupational aspect, it must be present in the workplace environment. And occupational exposure, I have detailed this earlier, so I don't have to dwell further. And exposure assessment also, as I mentioned earlier, is actually a process or an action to measure the magnitude, the frequency, the duration of exposure to an agent, and in this context to a carcinogenic agent, along with the number and characteristics of the population exposed. So you're not looking into one person, but you're looking at a group of employees when you're talking about workplace exposure. Okay, so how do we attribute occupation as a risk for carcinogenic exposure? And as we know, cancer is actually a long-standing process that happens before it manifests as a disease. And occupational cancer, at times it takes more than 5 years to be identified. So since it's a long process, there's a long latency period, it might be difficult to properly establish a diagnosis of occupational cancer. So basically there's often an underestimation of the cause-effect chain, whether it's being caused by the work exposure or non-work exposure, and what is the link to the workplace, and is there occurrence of cancer in only one person, or is a cancer cluster happening at the workplace. So the first thing that I mentioned is the less latency period, meaning from the first exposure to the onset of detectable disease. And then employees, who is handling what and what sort of exposure that the person is being exposed, at risk of, and then what sort of a job that he is doing. So when you're talking about job, there's a few ways to look into it. Let me explain from medical point of view. Let's say we are doctors, they group us as doctors, but when you're talking about doctors, we have occupational health doctors, you have anesthesiologists, you have pediatric doctors, doctors working in ICU, doctors working in the lab, and so on. So all of us are doctors, but the job title alone doesn't mean that we are being exposed to the same type of hazard. Even the job title is not going to help. For example, you're an anesthetist, but let's say you're an anesthetist working in ICU, but and then you have another anesthetist working in OT. So the exposure types who haven't worked in the ICU, but mainly stationed in the OT. So the exposure types are different, or even the scrub nurse in OT and the staff nurse in ICU. So these are the different types, groups of people who are within the same job title, staff nurse, doctors in ICU, but having different job scopes. And then we need to look further into what are the job specific aspects that they are being exposed to. They are being at risk of being exposed to substances. And as I mentioned earlier also, another thing that is making things difficult to attribute risk of developing occupational cancer is whether it's present in the general environment. For example, like consumer products, like bleaching agents or formaldehydes and so on, present in the general environment, and also in the workplace. So based on these aspects and the latency period, latency means somebody may just develop the cancer when they are retired and so on. So it's quite difficult to establish the diagnosis of occupational cancer, and is often underestimated. So if we go a bit back into the history, occupational cancer is actually quite a long-standing issue that has been discussed and studied way earlier. If we look back into the dark, during the Europe, before the Renaissance and so on, scrotal cancer was actually much discussed about in Europe. The Percival Port actually studied on scrotal cancer among those kids or teenagers doing the chimney sweeping work. I don't have the exact picture to show here, but basically if you can imagine during those days in Europe before the economical sweep came in, those who are actually cleaning up the chimneys, it's actually a very narrow sort of structure. So they needed these kids and also very scrawny, thin teenagers to go up, manually clean up the soot within these chimney spaces. And Percival Port actually studied that these kids were, and young men actually, when they grow to become young men, they had a higher risk, or they were found to develop squamous cell CA of the skin. So he actually tried to demonstrate that this cancer can actually be caused by environmental carcinogen. At that time, they grouped that together, environmental and occupation. And in Germany, however, even during that time, they had this particular practice of using a head-to-toe cover from preventing the soot from entering or being in contact with the body. Why? Because they also have noted this sort of changes, but they did take the initial control measures. So basically, to sum it up, they had this sort of like ecological general studies, but they never put it way scientifically. But they did find that occupation is actually a risk of developing occupational cancer actually. And then later there were many studies that looked into bladder cancer among dye factory workers, scrotal cancer among textile workers, among coal and oil product workers, and so on. And then only in 1934 they came up with the evidence to link asbestos and lung cancer. So this was actually a much later study that was being published, although the issue has been going on for years, but the evidential study was published in 1934. Okay, so coming back to the current times, what are we looking into when you're talking about occupational carcinogen exposure? Okay, so if we look at studies, they have compared actually middle income and also high income countries and to compare where are we heading to in terms of burden of occupational cancer. So studies have found that there's an estimated increased risk of 78% by 2030 as compared to the data in 2008 for the burden of occupational cancer to increase by 78% in the middle income countries. Another study also showed that there's estimated 50% of known human carcinogens are actually substances found principally in the workplace. And this is actually quite a shocking findings, because if you compare how much of these 50% are actually being studied, not that much actually. And another study also found that 3 to 6% of all cancers worldwide, meaning all the general cancers, are caused by exposure to carcinogens in the workplace. But unfortunately, only 5% of the global resources for cancer are being spent in these developing countries. And now, if you see here, I'm having two terms, middle income countries and developing countries. Why is that so? Because in recent times, the term has been changed, but when the earlier literature came in, it was used as developing countries, but the current literatures, they use the term as middle income and high income countries. Now, if we look or we zoom in to Malaysia, what is the issues that we are facing here? Well, occupational cancer is not that generally being discussed much or being studied about. And we still have many gaps in terms of understanding what's the prevalence of exposure to these carcinogenic agents among employees in Malaysia. Often we read about chemical exposures, we know about chemical health risk assessments, but if you're looking at carcinogenic exposure and studies that are looking into prevalence, it's actually quite limited and were quite limited actually. And another thing is when people are going or employees are going to submit the claim for occupational cancer, I think we saw from the slide by Prof. Victor just now how many cases being reported to DOSH, how many cases were compensated and so on. It's not that many as compared to many other countries. So if we are looking at this, so how are we going to attribute that cancer is actually caused by occupational exposure? We do not have that much of data. And next, if we are looking at the policy aspect, developing policy aspect for occupational cancer or occupational exposure control in terms of carcinogenic exposure at work and so on, we have to come with more solid policies. But this policy development process must be appropriately supported with data. Unfortunately, if we don't have enough studies and enough data to support the policy development process, then I'm afraid the policy will not be strong and will not be effective in implementation of control measures at workplace. And how will it be adapted and regulated within the workplace? So this is why we need to study on such aspects and elements. And here I'm focusing on carcinogenic exposure. And the other thing is, if you're looking at occupational cancer or cancer in general, of course, we have the national register, we have the national database and all that. But in recent times, based on my literature review, I found that this database was not recently updated. Why is it so? Because we only have a few cancer centers in the country that is capturing this data. And there is, of course, a limitation in terms of logistics, human resources and expertise. And even if that data is captured, it's being captured in a more general way. There's nothing looking in detail into occupation of the patient or what sort of exposure he had and further details and so on. So this essential information is actually needed to establish the diagnosis or for compensation purpose. It's actually a very long process. It has to involve many stakeholders to come up with what are the elements to capture this essential information. But having said that, if we have a very collaborated or collated network with these agencies, and if we have a proper database mechanism, then obviously this sort of information can be captured. Of course, in Malaysia, within this region, the Southeast Asian region, it can be a long process, but over time, with proper evidence, I think this can be suggested to the stakeholders. Okay, so earlier Prof. Victor spoke on occupational cancer, and I'm going to speak about carcinogen exposure. So where do we medical practitioners stand, and how much of contribution or role that we have to play? We have many hats. We wear many hats throughout the day, and we have many roles to play. And I would like to say that when we are talking about roles in all these components, for example, like in public health aspect, we can identify causes of occupational cancer. And then another important thing is to identify the trends of occupational exposure, and then what are the measures that we need to implement, and how are we going to do source control. So these are the aspects that we can look into from public health aspect. And then from occupational health aspect, we can look into what are the attributable factors for occupational exposure. And then another important element that we must understand is that these exposures are actually modifiable factors that we can actually control and manage within the workplace setting. So that is the beauty of it. Occupational exposures, they are within the environmental and occupational exposures, and these are modifiable factors. And then why is it important for us to control these exposures is, sorry, let me go back. So if we are looking into economical aspect, it is very important for us, the medical practitioners, to understand how much of disability this is causing within the society, and how much is it going to be used to identify what are the causes or basis for compensation claims. So that is another important aspect that we are looking into. And by understanding this, is also important to promote the return to work aspects, and also to promote the productivity within the workplaces. So another thing that we are looking at is individual measures, us as educators within the society. How much are we looking into to improve the awareness and to target the health education within the society, and to improve the health benefits for the employees. So basically from this we can implement behavior-based approaches. Okay, next I will speak on global occupational exposure trends to these carcinogens. So if we are talking about global occupational exposure trends, basically most of these studies were carried out within the European Union countries, and many studies were later adopted for the Latin countries and also the American countries and so on. So I will be speaking on that as well. And I'll be concentrating on a few important exposures. For example, I'll start with asbestos, the most common occupational carcinogen exposure that was studied. And if we look into past studies, I'm not going to go into very detail regarding this, but basically I'll highlight a few important studies that were being carried out. Asbestos, for example, it was based on a study in 2019. It noted that it was completely banned in 39 countries since 1983. And despite all these efforts, there are still many countries using asbestos. We still have more than 2 million tons of asbestos being consumed annually, and so on. Another paper in 2005 came up with findings that 9% of lung cancer in the world were attributable to occupational carcinogen exposure. And if we look at one of the recent studies by Prof. Lynn Frischie in 2016, her study estimated that in Australia, there's actually 14.59 million working age population, or an estimated 4.83 million cancer cases are actually due to exposures at work, including to asbestos. So asbestos was one of the elements that she studied on, and so on and so forth. There were many other studies looking into asbestos, and as recent as now in these Nordic countries, they had a very large scale study looking into what are the possible occupational environmental cancer, and they tried to link it for cholangiocarcinoma. So they did find an increased risk of exposure. So if we do a comparison and look into studies that dwell further into exposure among these developing countries and also developed countries, and they found that countries within the developing region has actually higher risk of exposure. The population has a higher risk of exposure as compared to those in the developed country. And further studies that adopted these findings into their local settings actually found that the countries that has a better safety and health regulation and have implemented better control measures has actually a lower risk by cumulative exposure. And in Latin America countries, they actually look into asbestos exposure based on the studies being conducted in the European Union, and they refer to the data that was used by World Health Organization back in 2019, meaning that these Latin American countries, they did not conduct their own objective study, but rather referred and adopted data from the European Union countries, and they found that the population attributable factors from CAREX were being applied and adopted for these Latin American countries. They did find that certain countries were actually having a higher level of asbestos exposure as compared to some other Latin American countries. So what I'm trying to say here is we have actually a lack of data, especially in the developing countries, regarding estimation of occupational carcinogen exposure. So to sum it up regarding asbestos exposure, in current scenario, 67 countries has actually completely banned asbestos. But despite being banned, it's actually being extensively used in many countries. Why is that so? Because of the very high market demand. And it's a very good installation material. It has very good thermal protective factor. It's actually cheaper than many other alternatives and so on. But it is causing millions of the population to be exposed to asbestos at work. And according to WHO estimates, more than 100,000 people die every year from asbestos-related lung cancer, mesothelioma, and asbestosis. And if they are looking into occupational cancer in general, 1 in 3 deaths are actually from occupational cancer. And also, if you are looking into mesothelioma, so mesothelioma has been attributed to be caused by asbestos if it's from the occupational setting. So this data also showed that the cumulative figure for this few countries, France, Germany, Italy, Netherlands, Switzerland, 200,000 mesothelioma deaths were expected over the period of 1995 to 2029, which is not very far from now. We are now in 2021, so 2029 is not very far. And I think after this period is over, then studies will be conducted to see how much of this exposure really happened. This was an estimate. Okay. So other carcinogens that are being studied, like the commonly studied one are like benzene, which is mainly used in plastic production, detergent, and so on. So this is being very commonly used as a degreasing material as well. So many studies were also carried out regarding benzene, but one of the recent studies in the Canadian population, they found that the exposure is actually only 2% of the work population being exposed. But another study in Brazil, by using the Finnish method, they found that the exposure is at 8.5%. And next is about crystalline silica dust. Crystalline silica dust has this being studied extensively. So there's actually 2 different schools of thoughts. One said that silica exposure and lung cancer, the association is unclear. And some other studies that found that the silica exposure is being linked to lung cancer. And other studies that look into exposure to silica also found that the prevalence to silica is 2%. So now 2% may look small, but actually when we translate that into the work population, it can come up to millions. Next is diesel engine exhaust that was being studied. So I'm talking about very common exposures that were studied over a certain period of time. And of course, not so recent, but over the past few years, we have known that diesel engine exhaust has been classified as a carcinogenic agent, and studies have conducted found that as high as 20% of the working population were exposed to diesel engine exhaust at work. And we also have ionizing radiation that was being studied. So if we look at international studies, they found quite a low number of population being exposed. But coming to Malaysia, we have frontliners being exposed to radiation, and then we have those working in manufacturing and engineering sectors are also being exposed to ionizing radiation. However, if we look into which of the aspect of the regulation looking into radiation exposure, we have to further read on NADOPAR regulations for Malaysia. It do cover on protection for employees from occupational exposure to ionizing radiation, but it is not very detailed out. And in Malaysia, we also have the ELB that is looking into radiation. Okay. And I'm going to talk a bit about environmental tobacco smoke. So we did carry out study in Malaysia looking into environmental tobacco smoke exposure. So why are we saying that environmental tobacco smoke is actually a workplace exposure when it's actually something because of a personal or individual being smoking and doing that activity on a personal basis when it's not generated from the workplace. But having said that, workplace is a place where control measures can be implemented in a very systematic manner, and with proper regulations, this carcinogenic substance can be controlled. So therefore, we need to understand what is the prevalence of exposure to environmental tobacco smoke in a workplace setting so that we can come up and suggest what are the proper control measures. So studies earlier have found that exposure was there, but these studies mainly focus on hospitality sector, food industries, and so on. So not much were being done about ETS exposure within the workplace settings. So other substances that were being studied were also like heavy metals and nickel and so on, chrome platers being exposed and so on. I'm not going to talk very much in detail, but these studies can be further read through ILO websites and also the WHO websites. Another aspect of exposure that was studied is the shift work exposure. So shift work has been of a topic of discussion of late. Why is that so? Because in Malaysia, employees work in shift work system, whereas in certain European countries and in certain Nordic countries, shift work is not being applied in general. So if we look into Malaysian law, we do have the Employment Act that limits the work hours, how many hours that the employee work and so on. And the law is there. But having said that, how is it being effectively implemented within the workplace settings? That is another question. And how is it being regulated? So from scientific point of view, we know that shift work disrupts our internal biological clock. And then we have this graveyard shift pattern. That means shift work after 12 midnight. That this being studied to found to have a severe disruption to the sleep pattern, digestion, and gene involved in cancer pathways. So studies have also found out, including one that was done by itself on the current knowledge of breast cancer among the Malaysian population and how studies from the European or other Western countries or population can be adopted for the Asian population. Okay, so now I will be sharing a bit of information about how this exposure was studied globally. I shared some data, I shared some information how the prevalence was like. So how actually was this prevalence estimated? Actually, it started back in Europe. If we look into European Union countries, they came up with this study that looked into occupational exposure to carcinogens among 15 European Union countries, and they found that actually 32 million workers or 23% of the employed people within this EU are actually exposed to 139 types of carcinogens at the levels above background, meaning more than the normal level. And if that is translated, it means that 1.3 exposures per exposed worker on average, everyone like some sort of exposure being present. And this is actually not a direct measurement study. This is actually an estimation study, meaning that they used the national data and they came up with what type of job that is being carried out by these employees, and then they estimated what sort of exposure that was being present. So they did not go to the ground. They did not do a direct measurement at the workplaces, but they estimated the data based on the information available in their national database. So this is how studies were being conducted to estimate exposure. And the findings of this study, they came out to understand that certain sectors, certain work sectors, for example, like mining, manufacturing, construction, were having a higher level of exposure or higher proportion of exposure. And asbestos, of course, was one of the commonly studied substance. And next, what they did, they adjusted this exposure prevalence to the economical structure of each country, meaning that they did a general study in the beginning and then they adopted the findings to adjust for the economical structures of the respective countries, like German, Ireland. They have different structures and they adopted that. Okay, and other exposures that were being commonly studied and were substances like leading to leukemia, like benzene causing leukemia, and silica causing lung cancer and all that. So this study is also funded by World Health Organization, and it was carried way back in early 2000s. And they compared that according to the regions of the world. For example, like how different is it in Africa as compared to the European countries and Southeast Asian countries, and they tried to estimate the risk. So they also studied only the common type of cancers, not the rare types, but types of cancer with common types of exposure. As I mentioned earlier, asbestos, benzene, these are the sort of common exposures that were being studied. And if we look into these slides, I am highlighting certain types of common exposures, for example, like arsenic, asbestos, beryllium, cadmium. These are the things that you hear constantly, whereas there's so many other types of carcinogens, but these are the common types of carcinogenic exposures that you are hearing very, very commonly in the globe. And the outcome of these diseases, like cancer of the lung, cancer, leukemia, malignant mesothelioma. And as I mentioned earlier, the attributable fraction for asbestos for causing malignant mesothelioma is actually 1. So some other rare substances are being also studied worldwide. For example, like coke oven work, it was studied in China, and then exposures that were being studied were like towards polycyclic aromatic hydrocarbons, formaldehydes, and then who are being exposed. So these are actually the type of dirty works as reported by ILO being causing the employees or the the blue collar workers to be at higher risk of being exposed. So if we look into classification, and if I can summarize it better, only certain types of carcinogens were being studied over and over again in the world. Why? Because of the use. Another thing is because of the availability of data. And the third thing is because of earlier existing studies, meaning that, okay, you studied on this and then we adopted the study and we studied. And we have to understand, if you're looking into national studies or WHO studies and all that, how much of access do they have to the workplaces for them to carry out a very detailed study? That is another aspect that they had as limitations. So what I can summarize from here is that asbestos-related cancers were the highest occupational cancer recorded, and it is also one of the most well-documented occupational cancer. But having said that, we have so many other exposures that we did not study, did not explore further, but our employees are being exposed. And in Malaysia, another worrying trend is because when we are talking about workplaces, there are many types of workplaces: manufacturing, agriculture, construction, and so on. And if we look further into, for example, like manufacturing itself, how many are large multinational corporations and how many are actually small and medium scale enterprises which has limitations for the workplace control measure implementations? And you'll be surprised that 85% of our industries are actually small and medium enterprises that has this limitation. So we have to understand what sort of this exposure, what are the limitations to implement control measures effectively. So when we're talking from research point of view, when you're talking from implementation point of view, what I can summarize here: number one, in this region, we still have insufficient relevant exposure data. Number two, we have insufficient risk data, and we do not have that many cases being reported or recorded. And hazard surveillance, as I mentioned, small and medium enterprises, the hazard surveillance can be something that is very, very difficult, more so in areas that there is lack of expertise. And why are we only studying on asbestos exposure when we have so many other exposures being present? And as from the studies, even from the European Union countries, you can look from the data that I presented earlier that those are actually data that was estimated from available data rather than being directly counted on the ground. So these are the issues that we are facing in terms of understanding occupational carcinogen exposure. So how actually people, despite all these limitations, tried to study and assess these exposures within the workplaces. So let me enlighten you on types of methods that we can apply and use to understand the exposure based on available techniques and measurement types or tools that can able to gauge and make us understand further about these exposures. So as I mentioned earlier, we had this landmark European study that used the national data. And then we had this another study that was being carried out in Canada, also used general data. So that was another subjective method of assessment. But of reason, not so reason, but compared to the earlier studies, the one that was being carried out by Australia in 2011 was actually one of the studies that looked into understanding real issues on the ground by trying to get further information regarding the job scopes and the job tasks that were being carried out by the employees. So in 2011, there was this study conducted in Australia that used this particular active and semi-quantitative surveillance method through direct questioning of the participants. And what they did, they targeted on the job tasks and work processes to identify and determine the exposure status of the workers. So how different is this study from the earlier studies is because they did some sort of measurement instead of adapting available data. So this is what we actually think is the next milestone or the next stage in properly understanding the exposures on the ground, more so at the national level. So if we look into the assessment methods and the tools that are being available, there are many types, definitely. One is the one that many of us know the industrial hygienists do, and the methods that are being used for direct exposure assessment. And we come up with quantitative or objective findings is by direct measurements, meaning we use tool, we go to the site, we measure what is the level of certain substances at the workplace and so on. But if we are looking into studies and so on, not all workplaces have this expertise, not all workplaces allow this sort of measurements to be carried out. But for legal requirement, of course, yes, certain chemical health risk assessment, they have to conduct this sort of assessment. And then we have the job exposure matrix. But job exposure, as I mentioned earlier, the comparison or analogy between doctors and nurses and so on, we are looking into the job exposure matrix, and we are looking at the job title and not something about the specific job task being carried out. And that itself can be a limitation because you don't understand in detail what job is being carried out. And then you have the self-reported methods whereby there can be a recall bias when somebody says that they are being exposed. Let's say the person is actually trying to do some compensation claims or is actually ill because of some other aspects, but when we try to feed them with certain questions, they will say, oh yes, I am being exposed. So there's an element of recall bias when you're asking people to self-report. So that is actually a limitation, but also being used in many settings. And then we have the manual expert assessment. Manual expert assessment means people or a group of experts, they sit down and look into the data of exposure based on the available information at the workplace or at national level or at the state level. And then they pool those data to come up with appropriate information about how certain workplaces or work sectors are at a higher risk of exposure. But having said that, it has its own set of limitations. One, of course, you need many people to look and sweep through this data. Number two, it's very time consuming and it's very labor intensive. So we have this new method that was developed in Australia that I mentioned earlier. Let me go back to the earlier slide. And this is the method that I mentioned earlier, the Australian Work Exposure Study, that looked into specific job tasks, meaning the experts look into the employee's history and what are the exposure measurement records and all that, and then they come up with subjective or semi-quantitative questions that assessed in detail what are the job tasks being performed by the employees. So these questions are actually more transparent and they're more consistent, and it saves the manual time and the logistic requirements of the manual assessment method. And how did they do that? They came up with job specific modules. So meaning within the manufacturing sector itself, for example, there are many types of jobs being performed, like wood cutting, you're doing some glue related work, welding, painting, and so on. So each job has its own specific elements being assessed, and from that they try to estimate what sort of carcinogen exposure that this person is being likely exposed to. And they came up with a list of priority carcinogens. If you look into the IAC list, International Agency for Research on Cancer, the list is actually quite long, but when you are looking into a particular country, or when you're looking at the list of carcinogens for a specific country, the number can be way lower. Like for Australia, they looked into 38 priority carcinogens. And similarly, we tried to adapt this list for Malaysia. So that is basically about how occupational carcinogen exposure is like, what is being done globally, and how the exposure is being measured. So there are, as I can sum up, you need to understand about the risk, you need to understand about the hazard, you need to understand about the exposure, you need to understand about occupational carcinogens, and then you need to know what is being done worldwide and what are the limitations in carrying out this exposure assessment. And next, on the ground, in the field, as a practitioner, what sort of measurement methods that you can use and apply to estimate the exposure. So this is the information that I'm trying to share with you all today. So next, I would like to share a bit regarding what is being done in Malaysia. As what Prof. Marzuki introduced just now, my background is on occupational cancer profiling, or occupational carcinogen exposure profiling, and my doctorate study was regarding this aspect, carried out with University of Malaya and NIOSH. We tried to profile the exposures for Malaysian work population. So for a start, we looked into certain work sectors, and as I mentioned earlier, we did not study on all sort of carcinogen exposures, but we have a priority list of carcinogens that we adopted, and we looked into the existing regulation, which is the use regulation. What are the list of carcinogens being studied? And you know, the Schedule 1, the Schedule 2, and so on. Many people think only Schedule 2 is limited to carcinogenic substances and all that, which is not right. Like as you can see from my slide here, we do have exposure to radiation, non-chemical agents like shift work and all that. That, of course, being present in Malaysia, you cannot limit yourself to the use regulations alone, but you need to also look into these carcinogenic exposures to understand what is actually like, what is actually it is like in Malaysia. So we did try to profile these carcinogens, and we listed out. How did we come up with this list? Of course, we refer to the existing studies, we refer to the regulations, and we looked into the work setting, mainly from the SOCSO database. What sort of manufacturing sectors are being present in Malaysia? What sort of work being carried out? So looking into those sort of literatures and articles and studies, we came up with a list of priority carcinogens that likely to be that is being present and likely to cause exposures in Malaysia, but we have to scientifically prove and come up with appropriate findings to support the policy process. So we adopted the latest method, which was the Australian method. They used the OC-IDEAS that I mentioned earlier, the semi-quantitative assessment method based on the for estimating the carcinogenic exposure, and it was actually a web-based application, and they used it in an epidemiological study setting. So in terms of profiling occupational carcinogen exposure for Malaysia, we also need to look into epidemiological setting as well. And then we came up with a few actions that we took. First is we determined the job category of the person being exposed, and then we ask questions based on the task that is being performed by the employee. And then next, the system automatically formulated the questions and answers with a pre-programmed algorithm, and came up with the risk of exposure, whether they were exposed at a high level, medium level, low level, or no exposure at all. And other than these pre-programmed algorithms, we did sieve through certain data to look and did a manual review to look into what sort of exposures that can be present. For example, when you're adopting a study or a method from Australia and which do not have work settings like electric and electronic industry, and in Malaysia, in Asian countries, electric and electronic industries are very common, and they do have certain types of exposure. So you still need to do some sort of manual review of the assessment. And this method is, as I mentioned, is a web-based method. Process is automated, and we program the priority carcinogens with occupational exposure into the system, and we came up with algorithms to set up the exposure rules to identify what is the probable level, and also the frequency. And how did we carry out this study? We actually call each of the respondents based on the SOCSO database. So ethically approved study, and in collaboration with SOCSO as well. And when we carried out this computer assisted telephone interview, meaning the participant on the other hand, they will be answering the questions for us, and we will be locking in the answer in the OC-IDEAS system. So based on the answer being provided, we analyze the data. As I mentioned earlier, if there were some issues or certain work sectors that needed manual review, we did the review as well. And from all this input, we estimated the occupational exposure to carcinogenic agents and tried to profile what is the actual exposure, what is it like for Malaysian population. And we came up with the findings. And of course, over time, we tried to improvise the study, and then we looked into what is the possible exposure likely to be present, and subsequently we came up with recommendations for the policymakers. So this is the example of job-specific modules and task modules that we looked into. For example, job-specific modules like caretakers, ceramic, cleaner, and all that. These are like, for example, within the manufacturing sector alone, because we started looking into manufacturing sector first. And as you can see on the screen here, one element looked into the job-specific modules, and subsequently it will link to the task being performed by the employees. For example, like asbestos related works, and then they have this asbestos removal process, and then burning works, cleaning works, cutting, and so on. So these are very, very specific modules that we looked into and asked the detailed questions about. So I would like to summarize the findings of the study when we try to profile. As I mentioned, we focus on the manufacturing sector. Of course, the study can be further expanded, and if we have the proper support mechanism and grant and so on, maybe we can look into other work sectors as well. And from our study, we found that exposure, the prevalence of exposure for occupational carcinogens in Malaysia among the manufacturing employees was actually at 78.8%. As compared to the Australian study, they had 67%. So when you're talking about exposure, this included the low, medium, and high level of exposure that we further subdivided into other categories. We also, because Malaysia is a multicultural, multi-ethnic population, we also looked into the ethnic backgrounds of the population. Why is that so? Because certain control measures, for example, the language that we use to do our health awareness and health education, we have to target and do in a certain type of language and certain types of setting or understandings. So we have to ensure that our program is tailor-made or in appropriate language and so on. Sorry. And our findings also showed that respondents from the lower income group were more likely to be exposed as they were more engaged in blue collar works like manual or semi-skilled works. And then we also looked into occupational groups based on the settings by Job Standards Malaysia, Department of Standards Malaysia. We subdivided the manufacturing sector into a few other categories, and we tried to look into these subcategories within the manufacturing sector. But however, certain group of occupations, the findings were not that significant, and we reclassified thereafter the occupational groups to come up with a more broader occupational categories. So to sum up, the prevalence among Malaysian work employees to for being exposed to occupational carcinogens at work was actually quite high in comparison to Australian population, and this provides some sort of evidence that indeed we need to study further on carcinogens at work and come up with further studies to look into what are the appropriate action and controls that can be taken. So this is first of its kind study that is being conducted in Malaysia. We looked into exposure to carcinogens, and we started with manufacturing employees. In fact, it's actually the first in Southeast Asian country. And we wanted to use the most efficient method for estimation of occupational exposure to carcinogenic agents. Now, as we can see, and as what I mentioned earlier, EU, European Union countries, they use a national data, they adapted a national data and so on. But that was a very subjective method that was looking into data alone without a proper measurement. And of course, we never go to the ground and directly measure, but we did use a semi-quantitative measure exposure assessment method. And then we also looked into small and medium enterprises, which make up of 80% of our manufacturing sector. And to start with, we had a very good collaboration with social security organization. So we did a look into their health screening profile data, and we looked into their manufacturing employees. We had the contact numbers. We were able to call and get them to participate in our study. So these are the strengths. And having said that, we are actually in our first stages of profiling this occupational exposure to carcinogens in Malaysia. Of course, this can be further expanded to other work sectors, and we hope to do so in coming times. So I think that's about it from me. And as you can see here, these are the important reference materials that are being used for my presentation and also my study. And some of the studies are actually quite recent as 2019, but the most extensive ones were the one being carried out by European Union and also by Australia. So thank you very much.
Thank you, Dr. Jasima, for the very interesting presentation. But before that, there's one question from Dr. Nani from Jakarta, Indonesia. She was wondering and curious on our numbers of cases of mesothelioma in Malaysia. As you presented just now, some numbers of mesothelioma cases in some developed and developing countries. And she was wondering on our cases, number of cases in Malaysia. And Dr. Zainul also suggesting on coming out with the registry for occupational cancer. So what do you think about that?
Okay, thank you for both the questions. I don't have the current figure for occupational mesothelioma in Malaysia, but basically the number is definitely lower, and we do not have a proper documentation about the number of cases being present that is being captured in the National Medical Registry. And I'm sorry, I don't have the current number, but what I know, it is way lesser, and that is one thing. And we have submitted actually requests to try to get this data and to try to link it because earlier I mentioned that the attributable risk for asbestos for mesothelioma is actually 1. meaning that if you can get the number, then you can know how much of this population being exposed, but I'm yet to get that. Now, going to the second question, we need to have an occupational cancer register for the country. Just to share with you, Dr. Zainul, we did have extensive discussion on policy aspects, what are the next term strategic plan and so on. Actually, I was part of that group of discussion that was held not last year, the year before, to look into what are the proper measures and how we can integrate occupational cancer related information into the National Cancer Registry. It is still in the stages of discussion, I would say that. So NCSM is actually looking into that.
Okay, following that, Jasima, Dr. Tam also was wondering whether we can, interested to know whether we can have a more focused kind of registry, like focus on lung or nasopharyngeal or skin cancer registry. So with such more plausible occupational relatedness can be developed, and the uptake of notification by our practitioners should be more forthcoming in the long term if we concentrate on certain type of cancer. What do you think about that?
Okay, I would totally agree with Dr. Tam. In fact, that was one of our recommendations to the National Cancer Society Malaysia and to the policy makers, and it's also part of the recommendation of my study that further information for this database has to be developed and integrated so that we can concentrate on certain types of cancer rather than, throwing a net and casting a wide net to cover all aspects, which resource-wise, logistic-wise, we may not be able. But having said that, we need to tackle on certain aspects. So highlighting on that, I will rather have us focus on certain types of cancer. For example, breast cancer and shift work. I think UM have also carried out study about relatedness of breast cancer and shift work. Prof. Nirmala and Dr. done that. So some of his recommendations also included how we can have better information in the country. So I will definitely agree with Dr. Tam. We need to do that. And as I mentioned earlier, we did have a discussion with the National Cancer Society. Let us see what they can come up with in the nearest future.
Okay, maybe last question before we move to our forum. With regards to chemical exposure monitoring, is it been conducted by our factory here or manufacturing factory here with regards to chemical exposure monitoring? Because many of our manufacturing company, especially small and medium industry, they are exposed to multiple type of carcinogen, especially chemical carcinogen.
Okay, thank you for the question. I have earlier mentioned, one is we have the multinational companies and we have the small and medium enterprises. When you're talking about small and medium enterprises, some of them are not actually that small. They can afford certain types of measurement. And yes, indeed, measurements are being conducted, but not by the personnel within the company, but they tend to hire the industrial hygienists, experts in the field of direct measurements to carry out this sort of measurements. It's part of the requirement of the chemical health risk assessment. So those that can be objectively measured, yes, based on the legal requirements, companies are indeed carrying out. And there's another method that DOSH has come up with, which is the subjective method to also assist the small and medium enterprises to estimate the exposure. So these are the two types of measurements. I'm afraid I won't have a very long time to discuss on that, but basically I can sum up that two types of assessment method exist. One is the direct measurement, another one is the semi-quantitative assessment being carried out for legal requirement purpose in the country. So that is being adopted by the workplaces.
Sima, thanks for your presentation. Thanks for your response to the questions. Okay, ladies and gentlemen, we'll move to our next agenda, which is forum. We'll have a forum of discussion on occupational cancer in Malaysia. Our panel today, we have Prof. Victor Ho, and then we have Dr. Wong Chi Kwan and Dr. Jasima also will be joining us in the forum. To start with the forum, as we know, in recent years, it has been becoming increasingly popular to carry out estimation of burden of disease with the aim of we want to identify major risk factors contributing to the important morbidity burden to aid on the risk reduction strategies. So in the area of occupational disease, in particular occupational related cancer, there's no exception on that. Yeah, number of cases, reported cases of occupational cancer in Malaysia is tip of the iceberg. What do you think on the actual burden of occupational cancer in Malaysia? Because reported cases is very small.
It is basically if you base on the risk factors and also on the what we call the exposure that we have in Malaysia. But when you use the data that is based on the risk factor, basically asbestos, although we say that asbestos is the highest, asbestos is the main source of occupational cancer in and around the world. But the issue is that the use of asbestos in Malaysia is quite low compared to other countries. This is basically a blessing in the sense that we were not developed during the time when asbestos was considered very considered widely. So if you look at removing asbestos from the equation, you look at what is happening in the UK number. UK number without asbestos is around 18 cases per year of occupational cancer. So Malaysia is around basically 5 to 18, 19. So I would expect that most probably we are underreporting by maybe three-quarter of the cases. There'll be another three-quarter of the cases that is we would need to look at. But of course we must also look at asbestos and also other kind of occupational lung cancer. Maybe Dr. Wong can share on lung cancer and whether what he sees in the clinic actually can be considered occupational or
not. Thank you. Following that, Dr. Wong, actually there's a lot of questions asking about the linkages between vaping and lung cancer exposure to as a risk of lung cancer. Do you have any data on whether vape itself can be the causing factors of lung cancer here? A question from Dr. Faiz here. Most of the occupational cancer were underdiagnosed due to knowledge of and awareness, especially among general practitioners, about cause of cancer itself, whether it's due to occupation. So what do you suggest to move forward to make sure that all our OHDs or our GPs are well aware about the occupational carcinogen?
Thank you, Dr. Faiz, for the question. Actually, I will split this question into two aspects. One is whether, first of all, are we requiring our doctors on the ground or our general practitioners or medical practitioners to diagnose an occupational cancer? So when you're talking about diagnosis of occupational cancer, first of all, it has to be a cancer, diagnosed as a cancer in the first place. And who is going to come up with a diagnosis of occupational cancer? Of course, it has to be those experts in the field, specialists in the field, and those oncologists and so on who can identify and say this is actually indeed a diagnosis of cancer. And then the occupational relatedness and the work relatedness aspect. So who can come up with this suspicion or fit the required aspects? So on the ground, our medical practitioners and occupational health doctors, number one, if they suspect a case of cancer, and then if they suspect element of occupational exposures, they have to come up and ask with the relevant questions to establish the link or give the appropriate input to the experts to subsequently diagnose this case as cancer and then next to categorize as occupational cancer. So when we are talking about giving the appropriate input and asking the right questions, it has to, the second aspect is going back to the basic education. So if we have proper modules, our proper knowledge is being shared to our occupational practitioners and the medical practitioners on the ground. And if we highlight appropriately in the module, what are the relevant information or relevant questions we need to ask to extract the information from the patients, and then I think we can have a better input or provide the better input to our experts to diagnose a case as occupational cancer. So it has to start from the very basic. We have to strengthen our modules. We have to strengthen our education mechanisms. And obviously, if we see maybe in postgraduate studies and so on, we have more understandings. But the basic modules, maybe we can look into, of course, they do share and teach about occupational cancer and exposures. But maybe for me, I think the knowledge is still very much lacking on the ground. That has to be strengthened, and our doctors have to lead by asking appropriate questions. That's my input.
Prof. Mazuki, can I also discuss on this? All right. Dr. Faiz, thank you for the question. I don't think diagnosing occupational cancer at the level of OHD is important. I think more important is basically looking at whether their role is basically doing medical surveillance. So medical surveillance is communicating not just communicating the information, not just doing medical surveillance, but also able to identify the early sign of cancer and basically able to reduce the sign of cancer, the risk of cancer. Because medical surveillance actually is the main thing that the OHD need to do. So if the OHD did medical surveillance and they will basically have all the data of information of the patient in hand. So this should be communicated with the doctor that actually the oncologist actually treating the patient, or the respiratory physician, or the rest of the physician treating the patient. That there should be a communication between these specialists from the GP side or the OHD side, and also from the specialist side. So there shouldn't be any trying to withhold information because it's valuable to each individual. If that, I think that is the way forward. Asking our GP or OHD diagnose occupational cancer is not difficult, but if they suspect occupational cancer cases and they might think it's occupational, then they should communicate it with treating physician to basically explore it further and discuss it further on that aspect. But the thing should start from prevention. Prevention is basically looking at medical surveillance and identifying the early sign of cancer. Thank you, Dr. Mazuki.
Thank you, Prof. Victor. So it's very important for our OHD to suspect that this cancer might be due to an occupational in origin. So it depends whether the patient come to you first or been referred by a respiratory physician, for example, because the respiratory physician might diagnose a patient with lung cancer. Then, it depends on where you are sitting. Are you sitting in the OH clinic in a tertiary center, or are you in the GP clinic? Okay, Dr. Wong, can I go back to you?
Yes.
All right. With regards to vaping as a cause of lung cancer, do we have any updates on that? And then, Dr. Zainul, Dr. Avinash also was interested to know on that issues.
Okay, thank you for the questions. So vaping is in the industry for a decade. Okay, it's like 10 years. All right, to develop a cancer, it may need even longer period of time to actually sort of like develop all these cancer later years, right? Not so soon. So you may actually find that, sorry, my daughter is behind me. Okay, all right. Okay. So the cancer may not occur so quickly, all right? But what we can know now is inside the e-juice, the vaping juice, there's a lot of carcinogens. In fact, there were about 20 substances or carcinogens, heavy metals that is found inside the e-juice, all right? That's the juice they use for vaping. And they also contain formaldehydes and the benzaldehydes, right? So the aldehydes are the ones that usually are the carcinogens. Whether it's going to affect the person who vape, yeah, definitely it will, but it's not so soon. We won't be able to see so soon at the moment because it's only 1 decade, right? And we need to actually follow up on all these patients, right, in a long period of time. Then we can find out whether is it truly that causes the cancer. The second thing is whether the secondhand smoke or secondhand exposure to the vaping products, whether they have a high chances of developing cancer. We still don't have data as it's so premature. And as what I said, we should actually do surveillance on the vapors, and we see the effect on the vapors first, then only we see what's happening to the exposure to the second-hand vapors, all right? So up till now, there's no concrete data, linking the vaping and the lung cancer.
Okay,
but
thank you very much.
Potential, yeah.
Okay, thank you very much, Dr. Wong.
Yeah.
Okay, thanks. We move back to Prof. Victor. Either Prof. Victor or Jasima can answer this. question from Dr. Abu. Another question on the underreporting among our cases. There's a very low occupational cancer being reported.
Anshia is breaking.
Why it is in the case? Most of the cancer in Malaysia, however, are seen and managed by non-OH trained doctors. So how do we ensure they look hard on the work relatedness of the cancer and eventually notify to DOSH? Prof. Victor?
As I mentioned earlier, that basically the occupational health doctor and the treating physician have to work together. But the problem is most of the time when you develop cancer, you're not working anymore, so the information is lost. If you're still working, then it's easy because your workplace you'll be sent by your workplace to go to the occupational doctor and to the physician, and the physician who basically knows that you're working, and they would basically contact the occupational doctor. So the moving forward is how can we retain this kind of information that the patient can carry with them on their way. So history itself would be very difficult. As Jasima pointed out earlier, there is an issue of what we call recall bias, and when you ask them, they say, okay, everything is yes, because there's a recall bias. So the better way is to look at how can we look at it from an electronic point of view and collect this data and store this data in a secure way that the patient actually can bring it with them whenever they go and see a doctor, so the doctor would understand whether it is occupational or not. Maybe Jasima can add something.
I think that is Prof. Victor has summed up what I wanted to say. The most important thing is we need sort of understanding from the treating physician themselves. For example, let's say it's a medical clinic or an oncology clinic, and they know this is an employee coming for treatment at their center, and they do have some amount of understanding or knowledge that could possibly be some sort of exposure, or let's say the employee themselves said, I work in a certain type of environment. So when you have occupational health physician or occupational health doctor within that setting who can come up with a better assessment and explore further those details and ask questions. I think one good example is what we have in whereby we have the clinic, other specialist clinic, and then we have our occupational health clinic where the specialists refer to us for further input from occupational health aspect. So if that sort of setting exists in many centers nationwide, of course, it's a very far vision, but it's doable. It's doable within the country. It doesn't have to be within the same setting, but if they have a very good collaborative network with other occupational health physicians, they refer, they share the information, or through maybe a digital method as well, if the information is shared, and they come up with some sort of assessment to say that it is possibly work related, then we can provide the relevant input to diagnose that it is or come up with a suspicion, even a suspicion or a proper diagnosis that it is a case of occupational cancer. But in Malaysia, who is doing the job now? SOCSO is doing. When the doctors submit the claim for cancer and so on, or the doctors directly submit a claim as occupational cancer, then SOCSO is doing the subsequent investigation. Like for my experience in yes, SOCSO do refer back to us, but this is only particular center because of the settings within but in other centers, how is it being done? So this is another way forward that we can implement in the country.
Okay, thank you very much.
Sorry, Mazuki, maybe I can ask Dr. Wong, what's the value of knowing whether it's occupational or not in the management of the patient? Because I'm so curious whether clinician actually cares about what occupation and whether there's any value in management when you're knowing the patient.
Okay, so I think it's a very important question, because when you know that there's a link between the occupation and the disease itself, the most important is compensation. Management of lung cancer patients are expensive, and a lot of time they have to actually fork out the money on their own pocket to manage their condition themselves. If let's say this disease is linked to the occupation, and if we can actually compensate the condition. Well, I would say that this is able to it's a win-win situation. We can actually manage the patients better. A lot of time, we only can give the lower range of treatment and not the best treatment for the patient. So I would say this is important as for compensation. And number two is for preventive measures. If ever we found that this is a link, and we should actually alert the occupational health doctors, and probably this should be further investigated and give a warning to that particular manufacturer or the company about the incidents.
Okay, thank you.
Mazuki, can I ask Dr. Wong one more question? All right, Dr. Wong, what do you think if we suggest that if any cases of, let's say you suspected can be occupational because from the type of cancer you get, let's say you get squamous cell carcinoma or basal cell carcinoma, which is basically the person is working in let's say in an industrial, would it be better just to refer them to an occupational physician, ask an occupational physician to ask to do the other part of the work that you don't need to do because you're busy doing your treatment of the patient? What do you think of that suggestion?
Yeah, definitely. But we as a clinician, we have to actually have the what you call suspicion first. If we suspect that this might be occupational related, then definitely we should refer to your occupational health doctor to manage the investigation part for the link. Yeah, but a lot of times, as you know, I think one of the question is regarding how many of our lung cancer patients actually smoke. It's about 90% of our male patients actually smoke. So you can't really justify whether is it the smoking that causing the lung cancer or the occupation itself that causing the lung cancer. Whereby for ladies, the female group, majority of them are non-smoker. And maybe if ever you found out that there's what you call unusual case of a lung cancer that's happening in that particular factory or company, then actually you should actually look into it and probably discuss with the physician or the clinician regarding the linkage of the carcinogens and the lung cancer itself. So for female, I would say we have to be more careful in assessing the risk. But for male, majority of them are smokers. 90% of them who develop lung cancers are smokers. So about 10% of them are non-smoker. So it's difficult to decide whether it's occupational related or not.
With regards to treatment of lung cancer, we are concerned about the compensation when we are looking into the cause of the cancer itself. I still remember when Prof. C.K. Liam referred the case of mesothelioma to us a few years back, when we know that the prognosis of this patient is very poor, but we did the investigation, tried to find the cause of that mesothelioma for us to compensate the patient, for their family, and also prevent other workers in that particular factory from developing lung cancer or mesothelioma. Yes, thank you very much.
Okay,
yes.
Doctor, can I ask you a question? How many cases of mesothelioma have you seen? Is it common in Malaysia?
So far, the histologically confirmed, I would say in my practice, I only saw 3. Okay, so 3 of them also very poor prognosis. A lot of time they presented very late, and they have to go through multiple investigations to confirm the diagnosis. Because the majority of them, they come in with a pleural effusion, pleural thickening, and we have to biopsy them. And sometimes it takes a while for the pathologist to come to the conclusion that this is a malignant mesothelioma. And when we confirm the condition, the performance status of the patient is quite poor. And a lot of time, the only treatment that we're going to initiate would be chemotherapy. So the doublet platinum chemotherapy. And with that poor performance and without much option, most of the time they succumb. So I would say that a lot of time they presented very late. In fact, there was a probably a recent mortality maybe last year, end of last year, and it was found to be a malignant mesothelioma. So I actually asked my team to actually have to notify this case, as a lot of time the awareness among the clinician itself also lack, and therefore there's not many of them will actually refer to the occupational health doctors. Yeah? So the awareness must be improved among the clinician and also among the private general practitioner and also the OHD.
Okay, thank you, Dr. Wong. Prof. Victor, there's a few questions with regards to shift work, the topic that you presented just now. Dr. Muhammad Izzuddin was asking on how to quantify safe shift work duration and cycle for cancer prevention. I know you presented just now there's some kind of link between cancer and shift work. Can we quantify the exposure or not?
Okay, thank you, Mazuki, and thank you, Izwan. Basically, if you're following my presentation, there is the shift work, what we call we still have not basically be clear on whether shift work actually causes cancer or not, because if you look at a lot of the studies done, most of the shift work and cancer, the odds ratio or the risk ratio or the incidence ratio is 1, and it is basically not significant. So the idea is whether shift work causes cancer or not. The jury is still not really clear. Of course, a lot of people will argue that yes, shift work causes cancer. So how to quantify shift work and cancer is also very difficult, because the issue is when if you look at shift work and cancer and you focus on melatonin as one of the factors that actually cause of the cancer itself, all right, you need to understand that is the person being able to adapt or being changed their lifestyle to actually the melatonin actually the level can actually increase because of the lifestyle changes. So to quantify it as how much is basically considered as high and how much considered as low is difficult. Of course, there are certain recommendations that is much better than other recommendations. They say that what we call the permanent shift is much better than a rotating shift, because permanent shift then your circadian rhythm actually will be stable. If you're talking about a rotating shift, a lot of studies have said that a forward rotating shift is much better than a backward rotating shift, but that also needs to take into consideration that some of the industry, let's say like your people who's basically doing air traffic controller, their working time is very short, which is 4 hours, and their break time is another 4 hours. So basically they prefer a backward shift because of the way the work is being done. So it's not easy for us to quantify whether shift work actually causes cancer now, first of all, because the studies that I've shown, the meta-analysis on my final slide, all of them actually shows there's no significant. Only study that still say that there's significant is basically the one looking at the shift work and melanoma, and that is something that basically we don't know the mechanism of how shift work can cause melanoma. If you're working shift, you should not be exposed to sunlight at all. So how can you get melanoma in that context? So the answer is I don't know, and I think that is the best answer.
Okay, thank you, Prof. Victor. Very interesting subject there. Okay, a lot more need to be looked into that subject. Okay, there's a statement by Dr. Zainul.
Maybe Jasima can add on the quantification, because Jasima is the one that do quantification.
You want to add anything, Jasima, on quantification of shift work?
Okay, shift work is actually, we did look into shift work, and then we looked into what are the job tasks, what are the specific tasks, and what are the specific elements of shift work, and how did we semi-quantitatively assess exposure. In fact, you'll be surprised, it's actually in Malaysia, high level of exposure to shift work within the manufacturing sector. I'm not talking about other work sectors because we are yet to look into that, but manufacturing per se, yes, indeed, we did have a higher prevalence of exposure to shift work. Why is that so? Because of our setting, our Asian setting. We work in 3 shifts, including the graveyard shift. It is semi-quantifiable, and certain elements we can measure, and but directly to quantify, I'm afraid no, we are not there yet. That is I think I'll conclude as that we are not there yet, but certain elements, yes, and based on our current study, high prevalence, we did come up with some recommendations. Of course, the recommendations did not go far away from the general recommendations to limit shift work in within workplace settings. But having said that, if we can do away with graveyard shift, that'd be good. Unfortunately, we can't. But if we can come up with certain aspects to minimize the risk of graveyard shift work, then yes, by all means, I would suggest that workplaces need to look and implement that. As for example, the light setting, the music, the background noise setting, the food being provided, and so that all that will help to ensure that the circadian rhythm is not that badly disrupted. This is also based on the international literatures that is being made available. Thank you.
Okay, thank you very much, Jasima. Okay, there's a statement by Dr. Zainul here mentioning that WHO and ILO has recommended National Silicosis Work Group. I believe in Malaysia we have this kind of technical working group also that share data on carcinogen exposure and control. So Jasima, do you want to share any updates on this technical working group that we're having now in Malaysia? Are you joining any of the technical group on occupational cancer?
I'm afraid I'm not a part of the silicosis group, but I was invited. As I mentioned earlier, the National Cancer Society was looking, and Dosh, indeed, I was told that they do have some technical working groups going on at the Asian platform and so on. But currently, I'm not a part of this group, so I'm not able to give input for Dr. Zainul's question. I'm not sure what. Yeah.
Basically, same answer with Jasima. We were there together in the National Cancer Society technical working group on occupational cancer. So basically, that was initiative to basically look at how can we improve notification or diagnosis of occupational cancer in the country, and we have come out with our recommendation. But the National Cancer Society of Malaysia is the one that is championing it. So I think if we want to discuss about this, we should invite the CEO or the director of National Cancer Society of Malaysia in the next sitting to ask him what is his thought and how is he going to move forward. Because I think it's better to move forward from the perspective of an NGO, in the sense that they have less burden of convincing, and also less burden because they are not part of the government itself.
Yes, agree with you, Prof. Victor. I think MSOSH has involved actively together.
Masuki, you broke up again. Yes, MSOSH have been actively involved together with the National Cancer Society in this group. The meeting was actually MSOSH was there, if you remember correctly, Jasima.
Yeah, MSOSH was there. Yes.
Right. Okay, we move on to Dr. Goh Chui Bui question with regards to COVID-19 and cancer. Dr. Wong, is there any linkages that you can see between maybe severity of COVID-19 infection with cancer or COVID-19 as a cause of cancer?
Well, this is a very interesting question, and a lot of people are also thinking how to manage cancer patients in the COVID pandemic, rather than thinking of like COVID is the reason for the cancer. Well, as you know, it's only like 1 year. We couldn't like find out whether is there a link of like COVID and cancer, but we have seen that if you are immunosuppressed or if you are on treatment and you develop COVID, your condition can be worse than the usual people. All right. So, but so far in my practice, we have not seen any concomitant conditions like COVID plus lung cancer, because we manage a lot of lung cancer patients. But of course, we try to limit their exposure to the hospital. And of course, our lung cancer patients, they are very, very careful. They don't really necessarily. They take care of their hygiene, and then we also give them appropriate what you call advice during this pandemic. And a lot of time they still come back for chemotherapy, but majority of them, so far we have not seen anyone who actually had contracted COVID. But now the situation is getting bad to worse, and it's in the community. Probably in a few weeks' time, we'll see some of those patients get admitted with concurrent COVID infection, and usually they will do worse as compared to the other patient without cancers. Yeah, because they have a poor lung function already, and on top of that, let's say they develop acute respiratory distress syndrome or organizing pneumonia, that will actually make them worse, right?
Okay, thank you, Dr. Wang. Okay, next question from Dr. Wan Saudi Sani. Since this is with regards to KKM, I ask this question to Dr. Jasima. What is the current KKM surveillance and improvement to prevent rising of incidence of cancer among factory workers? Is it a responsibility of OHD or our Ministry of Health?
Okay, if you're, I'm going to answer from KKM perspective, is it? Okay, just for information, I am in KKM, but my role is currently on management of COVID clusters. The surveillance needed and how workplace settings can be improved and so on in terms of prevention of occupational cancer and exposures. But the role, of course, is quite limited, and DOSH has a bigger role to play. DOSH has a better suggestion for mechanisms and surveillance, whereas Ministry of Health, they are part of those providing the input.
Thank you, Dr. Jasima. Next question goes to Prof. Victor by Dr. Aniza Abdullah. Is it possible for Malaysia to ban the usage of asbestos? As we know, we have partial banning of asbestos for years, and we are planning to have total banning. So when we can have this total banning of asbestos, Prof. Victor?
I think we're in the process of total banning of asbestos, but because the thing complicated, there's some complication due to the current COVID pandemic. So before the COVID pandemic, we were in the process of banning asbestos and also coming out with the new Occupational Safety and Health Act. But of course, although asbestos is not banned currently, all right, but there are already many legislation actually prevent the use of asbestos openly. So you want to import asbestos, you got to go through the custom regulation, and usually custom does not allow import of asbestos. Of course, then you want to use the asbestos, or you got to go through other regulations. So the issue is banning of asbestos is just the first step. All right. The second step is basically how to remove asbestos that's still present in the country. Of course, you don't remove them unless it's during when you need to do removal. We don't have, I don't think we have a process of actually ensuring that when you remove asbestos from buildings or remove asbestos from other asbestos containing materials, ACM, and how do we dispose of it? Whether this one's supposed to be disposed of as a what you call that, schedule waste or not? Actually, so that is the more important things to focus on. Currently, the use of asbestos in Malaysia, the amount used is quite small already.
Okay, thank you.
Maybe just Jasima one can add about her experience in DOSH maybe on asbestos.
Okay. I was previously in DOSH from 2010 to 2014 before furthering my studies. So I was serving as the director for Occupational Health Unit. And during my experience and from the latest input that I gathered, we still have about 16 to 17 industries actively using asbestos in Malaysia, meaning asbestos related products are being used within these industries. So the process of developing the regulation and proceeding towards ban actually started way back in 2010 and yet to reach a conclusion. it is actually quite a lengthy process. Of course, we have a lot of education programs being held for our practitioners with regards to identifying occupational exposure to asbestos, about conducting the surveillance and so on, and then subsequently the changes in the level. But banning wise, I think it is still in progress. What do you think, Prof. Victor? How long some more it will take?
I think it should be soon, because there are a lot of lobby groups still around, basically from Russia and from other lobby groups. Basically, they have strong. So
yes, I agree with Prof. Victor. The Crystalline lobbyist is very strong. They'll be attending all our conference and asking questions.
I think those who have been in the field and those who have participated in our international conferences, whatever we have in Malaysia, would be well aware that whenever we have such programs and we have speakers, we do have these lobbies coming up and giving their counter arguments and all that. Of course, we have to listen to both parties. They have their concerns, we have our concerns, but ultimately our aim is to ban asbestos in Malaysia. So how far we have come, yes, it depends on the political climate and how important the issue is to be pursued further. So if it's an important issue to be pursued, there's a high level of concern, then it will go fast, further, sooner. Currently, no. Let me summarize as that.
Okay, thank you very much, Prof. Victor, Dr. Jasima. Dr. Wong, there's one clinical question for you with regards to is there any physiological cause for minimal one-sided pleural effusion with normal spirometry, asymptomatic, and no evidence of PTB, malignancy, or heart problem?
Well, I can't really answer that question. Yeah, that's very clinical until I really assess the patient myself. So it is asymptomatic without any identified cause. I still think that if ever we can actually tap the effusion, and we should tap the effusion and find out, or if let's say it's too minimal, then should go for CT thorax, okay, contrasted CT thorax to find out whether are we missing something like lung cancer, right? So it's still possible. So asymptomatic with a minimal effusion, and you don't know what is it, the commonest cause is still either TB or lung cancer.
Okay, thank you, Dr. Wong.
Dr. Wong, sorry.
Probably Dr. Sina can refer to Dr. Wong later.
Dr. Wong, I want that to go first. Okay. Basically, there are people from there are physicians in other countries that says that use the spiral CT as a screening tool for to detect early sign of cancer and to follow up cases where there is minimal changes for cancer.
So lung cancer screening is still not well developed in Malaysia, and it is very costly. So if you're talking about getting a CT done in our government setting, it should cost about at least 300 ringgit. And as for the private setting, it can cost up to 500 to 600 ringgit just for a normal CT of the thorax. And we are talking about low dose CT scan because we are trying to minimize the ionizing radiation as much as possible, because it's also a risk factor for developing a lung cancer. If patient is younger than 55 years old, no smoking history, no family history of cancer, I wouldn't jump into conclusion of getting what you call CT done. But if let's say they have risk factor, possibility is higher of developing lung cancer, then it's justifiable to do the CT scan. Because in studies which is done in younger population, less than 40 years old, if you do spiral CT, all those things, the detection rate is about 6% or lower than that. So it seems like it's not cost effective, and it's going to be a burden to the country. So therefore, we have to, if we want to screen, we have to be targeted. Especially as we know already in Malaysia, around about 50% of the male smoke, and 90% of the smoker that have lung cancer. The lung cancer, the male, 90% of them they smoke. So it is still the major cause of the lung cancer. But of course, if we can detect the early nodule, we can biopsy, we can remove it, and that will actually save a lot of money. In the sense that when they presented to us in the late stage, advanced stage, they need to utilize the what you call medical treatment, higher medical treatment, inpatient care, chemotherapy, immunotherapy, all those things, which I don't think our government can support as much as possible. So majority of them will be palliation therapy, which is also is not well developed in the sense that although we know that there's palliative care, but it's still not very well established in a certain part of the country. So so I think that it's important to get the lung cancer screening by doing a low dose CT, but you must have good support from many teams, because as I shown in my slide, managing lung cancer is not just screen or you have lung cancer, that's it. No, that is only the starting point. So you have to refer the chest physician for biopsy. You have to do further images like MRI brain, the PET scans, all those things to stage the patient accurately. And when it's staged, then you have to do further testing. So this is going to cost a lot. So we have to have a support from the government and also many other teams to make the lung cancer screening workable.
Dr. Wong, do you think that paying 300 ringgit a year for a low-dose CT is the same like what you spend for smoking, what you spend for Netflix? So would that be worth it? If I'm a smoker, I just pay 300 every year. I just do a low-dose CT, and then I say, okay, my lung is clean. I can smoke for another year. Next day I do again. My lung is clean. I can smoke for another year.
So, which is a totally wrong concept. So we have to delve into smoking cessation. And smoking cessation clinic, although in government setting there are smoking cessation clinic, but we still don't get enough of the support, meaning in the human resource. So a lot of people is not trained on how to deal with smoking cessation. And in fact, unfortunately in we do not have an established smoking cessation clinic for the public, but for the staff, we do have certain service for the staff, but not for the public. So this is that I think everyone should actually contribute, particularly when seeing a patient who smoked, try to advise them smoking cessations. Smoking cessation also not cheap, the treatment. But of course, if let's say if they use smoking cessation treatment to replace their smoking habit, it's actually worth it. It's actually worth it. So I think we have to delve into the prevention. Yeah.
Okay, thank you. Prof. Victor, we have a question for you. Most of the time, cancer, when it's happening, the exposure is quite long time before, and the incubation period can go up to 30 years. Workers might not be working in that particular factory anymore, and the exposure, the task might be different already. So there's a question by Dr. Zulfikar Razak here, whether there's any example of employers empower their workers to keep record of their exposure or not, so that when they develop cancer, we can know from where the exposure is, maybe from their previous work and so on. Any comment from you, Prof. Victor?
Thank you very much for the interesting question. Currently, I don't think any employer or any studies or any program has been carried out for employee to actually keep their own record. But I think this should be done at a national level, where I think DOSH leading and then taking into and the national registration to actually keep the record of all exposure of all the workers in a secure manner, so that this one can be transmitted to the doctor when they go and see the doctor. Then there will be no problem of what we call recall bias. There's no problem of what like Jasima say, apa pun ada. When they ask adakah ada because of they want to get compensation or they want to get that. That's a very good what we call a suggestion that I think we should look in that more deeply. But of course, we still remember our national registration card. Our IC is supposed to have everything in one, and also there's also the national health record. So if we have the national health record, then it will be much easier for us to actually look at that and then put the exposure history in the national health record, and they can carry with them wherever they go.
I think it's in a regulation whereby the employer responsibility to keep all the medical surveillance record up to 30 years. So in case if the workers having any contacted with any disease, they can refer back to this record from the employer, regardless.
Yes, correct. Thank you very much, Mazuki. If that is the medical surveillance record. Thank you.
Okay. Next question goes to Jasima. Jasima, with regards to your previous study, what do you think of formaldehyde carcinogenic exposure among hospital laboratory personnel? And how do you adjust the OC-IDEAS estimation from Australia to Malaysia, since we have a different job scope? And then maybe the third one, how many participants in your study using the phone call? Because it's quite time consuming.
Yeah. Okay, so maybe I will answer the first one is about formaldehyde exposure among hospital workers. Number one, my study looked into manufacturing sector. I didn't look into formaldehyde exposure among hospital workers. But our question, actually, if we can tailor the elements to suit for hospital settings, yes, we can study on that, but I don't have the data. But in Malaysia, for formaldehyde, exposure among manufacturing workers is actually quite low, less than 2%. Yeah, less than 2% of the manufacturing workers, because it's not being widely used in the work industry. Number two is how did we adjust the question to suit Malaysian manufacturing employees? Yes, as I mentioned earlier, the questions were initially developed to suit for Australian setting. Now, if you look into what is the difference between Australian setting and Malaysian setting, number one, their manufacturing sector is a bit different from us. For example, Asian countries and Korean, Japanese countries, we have a lot of electric and electronic based industries, which means the exposures to certain types of carcinogens is also different. So I had to explore further into that and study what sort of exposure exists within our manufacturing settings. So first of all, I had to identify what are the subsectors within the manufacturing industry in Malaysia. Number two, I had to consult the industrial experts to understand what are the work processes and job tasks being carried out within these certain sectors. For example, this electric and electronic industries, what are the job tasks being carried out? Then I had to alter and adopt the job task module to suit this sort of industries. So we did that at the next stage. And then the third setting was we had to look into types of PPE or attire being worn. So exposure also means like, skin exposure, contacts and so on. For example, like solar exposure among construction workers and wood workers who are working outdoors and so on. We had to tailor make the question to suit their attire being worn. As you know, in Malaysian settings, the dressing is more modest as compared to Australian setting, and women wear hijab and so on. So we had to include those sort of elements or scopes within the question to understand what is the exposure to sun and outdoor exposures. We tailor-made the questions to that extent. Of course, we did have a lot of appointed. I had about 11 appointed industrial consultants who we officially met and asked to gauge better understanding about how manufacturing sector works. Because when you're doing a field study, you cannot be doing from an academical point of view or from a scientific point of view alone. You have to understand what are the issues going on the ground so that whatever suggestions you are going to come up with can be very practicable. Number three, I had about 511 participants to answer about how many people I had within the study. 511 participants who took part in my study, the final number. that we vetted and finalized a sample size for this study. We contacted 1,200 and plus, but we had our inclusion criteria, we had our exclusion criteria, so we had to exclude certain people who did not fulfill the criteria, certain people whom we called who did not want to participate. So the final number was 511 participants, and each session took about 20 to 30 minutes. So some phone calls we had to do for about 2 or 3 times when we found that the information is insufficient, or the participants asked us to contact back at a different time because they're working and so on. But the beauty of the system that we developed for the study is you have to answer in stages, meaning the next question will not pop up if you never answer the previous question. So we had to find the appropriate time. But basically, to sum it up, you need about 20 to 30 minutes for each participant. So it actually took us a bit of time to get the proper list of questions and synchronized answer from each respondent.
Yes, thank you, Dr. Jasima. You was very determined while doing the data collection last time. All right, next question comes from Dr. Glenn. Maybe Prof. Victor can answer this. Do you have any data on cancer cases among oil and gas, oil and petroleum industry workers, because they're being exposed to carcinogen? So do we have any data on this?
I think I don't have, maybe SOCSO would have, but the number of cancer cases have you seen earlier is basically between 12 cases and 8 cases. 5 cases per year. So this data SOCSO should have, because they don't share this data openly because it's all private and confidential. So I think should just get from SOCSO. Glenn, okay. Sorry about that.
All right, thank you. Next one, maybe Dr. Wong can answer this question. With regards to dedicated OH subjects should not only be incorporated into undergrad program, but also postgraduate clinical master program. What do you think of incorporating OH subject in your, for example, like master of internal medicine program, for example?
Yeah, that's a very good suggestion. In fact, in undergraduate, we actually touch on occupational occupational lung disease, but not particularly on cancer. So majority of those we involve would be airway disease or interstitial lung disease or so on, rather than lung cancer. So because lung cancer, the number one causative is still smoking. So therefore, the what you call concentration on the lung cancer itself is basically on the smoking cessation. So as for the postgraduate curriculum, we do not actually concentrate a lot on that. But for the our training for our fellow, we actually included into one of our essential curriculum that they need to know about occupational lung disease. So again, more concentrating on occupational asthma and interstitial lung disease rather than cancer secondary to occupational exposure. But this is something that we need to emphasize and improve the awareness among our doctors, and probably during our undergraduate or postgraduate, or in fact during our fellow teaching, we should actually emphasize more.
Okay, thank you, Dr. Wong. We are at 1 o'clock already now. We have last question from the.
Masuki, you broke up again. You broke up again.
Okay, Dr. Vanita was asking on an emerging hazards that we exposed to the 5G electromagnetic wave. Do we is there any finding on the side effect of 5G wavelength, and what would be the possible occupational effect from the exposure to this 5G electromagnetic wave? Maybe Prof. Victor or Jasima can entertain us on this.
I think Jasima is the best person to do it. Yes, so much on
exposure, yes.
Yeah, so basically, Dr. Vanita, we have 2 types of exposure, right? Ionizing radiation and non-ionizing radiation. If you look at global studies that looking into non-ionizing radiation, there is yet to be very conclusive evidence to suggest that non-ionizing radiation is carcinogenic. It is yet to be classified in that way. And if you're coming further into 5G, and whether it's carcinogenic and so on, I don't think so. We have adequate or sufficient data to say that it's indeed carcinogenic. I did not come across any such data, but I'm not sure in the past 1 year while we are busy with this pandemic, any further studies came up to. Prof. Victor, are you aware?
Sorry, not aware, but you must understand the wavelength. Basically, it's not the G, it's not 5G or 4G or 3G. It's the wavelength that they use for transmitting the data. So the higher the wavelength, I'm not sure whether the shorter the wavelength or the higher the wavelength, when more energy is needed. So the older handphone basically needs more energy to transmit the data, because they have less transmission tower or transmission base. But the current handphone, you look at it, there is transmission base everywhere. So the energy that's needed is actually very low compared to the older handphone. So if you look at it, if you think that what are the risks of non-ionizing radiation, the non-ionizing radiation risk is basically higher during the time of the older phone because of the less, because they don't have so many. I think the long wavelength, so they can travel further, and basically the long wavelength would make them that they need more energy for them to transmit the signal. So that is more important than just the 3G. 3G is just the technology of how to convert. Is not about the the energy use or the wavelength. So the wavelength is still important.
Okay.
I think the best person to answer this is our distinguished professor, Dr. Prof. Ng Kwan Hong. He has a lot of information on this. Maybe next time we can ask him on that. What his thoughts on 5G.
Yes, that's right. Okay, thank you very much, everyone. Maybe before we end, can we have final say from each of our panel? Just a short one. Prof. Victor, you want to start first?
I think the main thing I want to say is thank you very much for all of you being here today. I see that there's still 74 of you here, although we are here for 4 hours. This means that you are very interested in occupational cancer. And we are just trying to share the information on occupational cancer. So the first thing is we must basically have a high index of suspicion when we look at whether there's exposure now. So exposure history is one of the most important part of occupational practice. So asking a good exposure history and getting a good occupational history is very important. Thank you, Prof. Marzuki.
Thank you, Prof. Victor. Dr. Jasima.
Okay, first of all, thank you for allowing me to be a part of this interesting webinar. My apologies for earlier technical glitches, and we have a very long way to go in terms of doing more research for occupational carcinogens exposure or reducing the burden of occupational cancer in Malaysia. What we are seeing now is just tip of the iceberg. It does not mean that we have less number of cases being reported. It's the actual situation on the ground. The most important thing is how to identify the occupational relatedness of these cancer cases and to reduce the further exposures at workplace so that we do not have more cases developing within the population. So end of the day, we want to reduce the cancer burden in the country, and we as occupational health practitioners need to see how much we can contribute from the occupational health perspective. Thank you.
Okay, thank you, Dr. Jasima. Last but not least, Dr. Wong Chee Kwan, final say from you, Dr. Wong.
Thank you for inviting me to join the webinar. It's a very interesting topic. I also learned a lot from Prof. Victor and Prof. Jasima. Okay, so for lung cancer, the most important message would be early detection and then aim for cure, and so that the patient will live longer. So this is what we are trying to do. But unfortunately, there are so many factors that we cannot control, particularly on smoking, right? So the industry, the tobacco smoking industry is still very rampant. On top of that, now there's more other industries such as vaping industry. So we need to have a very solid policy, the government policy in controlling tobacco. We are trying to fight against this, but unfortunately, seems to be a long way to go for us. So therefore, we should advocate smoking cessation in any way, if possible. And of course, early detection if ever we suspect anyone with a potential risk factor of developing lung cancer.
Academy of the AOEM will be organizing a live webinar on managing COVID-19 through 2021. We have a line of distinguished speakers here, including our former Deputy DG of Medical, Dr. Rohaizat, our ID specialist from Hospital Sungai Buloh, Country Head Manager, Dr. Edwin for Shell Malaysia, Dr. Jan. Yeah. So please join us. It's free of charge for AOM members, and it's 50 ringgit for non-AOM members. So it'll be a very interesting webinar on COVID-19 vaccination. With that, thank you very much, everyone, for joining us today. I hope you have a beneficial webinar and gain a lot of information from this webinar. Hope to see you all again in the next webinar. Thank you very much, everyone. Bye-bye. Assalamualaikum.
Thank you. Bye-bye.
Thank you. Bye.